Días. Les agradecemos su asistencia. Estamos empezando el Congreso del capítulo de Cirugía Artroscópica del Perú de este año, después de ausencia por la pandemia. Lo hacemos presencial. Vamos a empezar con el bloque de artroscopía de cadera y tobillo. En primer lugar, tenemos un invitado, el doctor Thiago Fuchs, que nos acompaña desde Curitiba, Brasil. Él se va a encargar de tres temas: la evaluación clínica de la cadera joven, exámenes de imágenes aplicados en artroscopía de cadera y cómo reducir la curva de aprendizaje en artroscopía de cadera. Con ustedes el doctor Thiago Fuchs.
Buenos días. Primeramente, muchas gracias por la invitación. Yo soy muy honrado de venir acá en otro año, en 2019. Fue muy bueno y ahora estamos de vuelta. Yo voy a hacer 3 charlas con conceptos un poco más técnicos y prácticos sobre la basis de la cadera joven, de las cuestiones mucho más relacionadas al examen físico y cómo empezar el trabajo, porque hay una visión de las dificultades de la artroscopía de cadera y la verdad es que los conceptos básicos son muy importantes. Entonces, las 3 charlas son muy interligadas. Voy a empezar por la evaluación, después cómo correlacionar los exámenes físicos con la artroscopia y después cómo facilitar su cirugía de artroscopia de cadera. Bueno, yo trabajo en Curitiba, Brasil. Yo trabajo junto con un auxiliar de cadera y rodilla y con mi papá, que mandó un abrazo a todos sus amigos acá. Entonces, la verdad que la cadera es como todas las otras articulaciones. Nos tenemos que tener una rutina en toda la evaluación. Tenemos que oír al paciente, tenemos que examinar, tenemos que hacer testes y pruebas específicas y tenemos que entender que no todos los dolores son de la cadera. La cadera puede tener dolor de la lumbar, del abdomen y dolores irradiados. Entonces, existe un concepto de evaluación neuromuscular en capas que viene del Dr. Hal Martin de Dallas, que tenemos que entender que los dolores pueden ser articulares, extraarticulares o neurovasculares. Entonces, pensando en la historia del paciente, en hombres, tenemos siempre que entender la edad y las principales causas del dolor. Entonces, el pinzamiento femorocelular especial al CAM, la pubalgia, la osteonecrosis, doenças de la adolescencia como efisiolisis y artrosis son diagnósticos muy frecuentes en la cadera joven. En las mujeres, tenemos que entender que el pinzamiento es más común, es tipo pincer. Porém, 20% de las mujeres tienen caderas con pincer y apenas 3% tienen desdolor. Entonces, no son todos los pincers que son la doença del pinzamiento. Las pacientes mujeres son muy frecuentes la displasia de la cadera, los dolores laterales de cadera y muchas veces alteraciones inflamatorias reumáticas. Son muy importantes cuestionar sobre las actividades específicas de cada paciente. Dolor para sentar y dirigir, dolor para agachar, dolor para cruzar las piernas. Quais são as atividades físicas que hacen, se hacen atividades de hipermovilidad, se hacen deportes de contacto o con pivô, ou se hacen muchas atividades com mobilidade e flexión excesiva. E a dolor. Creo que a pergunta mais importante em la cadera joven ¿tiene dolor e onde tiene dolor? Normalmente la cadera se duele en la anterior, en la virilha. Pero muchas veces los pacientes creen que el dolor posterior o dolor glútea es de la cadera. Puede ser, sí, puede ser, pero es una dor atípica y tenemos que siempre estar atento al tipo de dolor y para cuándo tiene dolor. Si tiene dolor para practicar actividades físicas como flexión o si tiene dolor para deitar en la cama lateral, son diagnósticos diferenciales para se saber qué caderas tiene que operar, qué caderas no tiene que operar las alteraciones radiológicas. Muchos pacientes reclaman de pérdida de movilidad. Son las mujeres que acusam de dificultad para cruzar las piernas y los hombres de calzar los zapatos. E também sempre questionar se tem algum problema de cadera en la infancia, en la adolescencia, en las mujeres, especialmente la displasia, en los hombres, las doenças de pele, fisiolisis ou algum trauma, ou com fixação ou fraturas. Tem sempre que no jovem questionar sobre os hábitos de vida. Temos sempre que excluir as doenças inflamatórias, a osteonecrose, o uso de medicações, porque muitas vezes o raio-x mostra o pensamento, mas a ressonância mostra outro diagnóstico juntamente e o tratamento é muito diferente. A avaliação física me gusta sempre também seguir a rotina. Teremos que mirar o paciente em la postura erecta, caminhando. As marchas em rotação externa são muito clássicas da perda de mobilidade e rotação interna. Em contrapartida, as marchas em rotação interna são muito sugestivas de displasia. Então, muitas vezes, viramos no início da consulta o paciente caminhando e sabemos se é um paciente com pouca mobilidade ou com muita mobilidade. Também me gusta muito a avaliação postural, porque os pacientes com pensamento que têm uma postura em retroversão da pelve, com a coluna lombar retificada, não têm capacidade de compensar os problemas biomecânicos. Então, os pacientes que já têm a postura em retroversão com lordose erecta não têm bom resultado com tratamento conservador. Sempre temos que palpar os pontos de dor. A cadeira, ela tem como circunda todo o tronco, temos pontos de dolor anterior, laterais e posteriores, e teremos que saber palpar todos os dolores para entender. Não é uma dor na cadeira, e sim uma dor na cadeira anterior, com características articulares ou não, uma dor posterior, uma dor muscular. Sempre avaliar a amplitude do movimento. Me gusta fazer com o paciente deitado, podemos fazer com o paciente sentado. E os principais movimentos, temos que ver se o paciente tem uma flexão adequada ou uma perda de extensão. Teremos que avaliar a rotação interna e se tem uma variedade um pouco distinta entre os pacientes, pero na média 30 graus. Em homens de 20 a 30 e mulheres de 25 a 40. Se temos amplitudes de movimento muito exacerbadas, temos que mirar a versão do cuello femoral. Pacientes com retroversão de cuello femoral normalmente têm uma pequena rotação interna e tem uma grande rotação externa. Já os pacientes com anteversão excessiva têm hipermobilidade. Têm as mobilidades de rotação interna de 40, 50 graus com rotação externa de 90. E são pacientes muito delicados para o tratamento quirúrgico da cadeira preservadora. O principal teste da cadeira articular se chama FADRI. Melhorando, era um teste dinâmico de flexão, adução e rotação interna. E se tem uma informação importante nesta charla é isto. O teste de FADRI não é um teste específico, e sim um teste que ele diz se ter dolor. É o melhor teste para um dolor articular da cadeira quando o dolor é articular ou anterior. Porque se tem o dolor lateral ou posterior, isso pode sugerir uma patologia trocantérica, ou uma dor glútea, ou um tensionamento do piriforme. Então, não é porque o teste é positivo, e sim se o teste é positivo em local de dolor. O teste de Faber é dinâmico também, é muito importante entender a ubicação do dolor, onde é, se é anterior ou lateral, ou se é posterior. O teste de Legg para testar as tendinopatias de pessoas compensatórias. O teste de subespinhal, uma hiperflexão forçada, muito clássica do impacto tipo pincer subespinhal. E os dolores nos testes de rotação externa com hiperextensão. Dolores anteriores sugerem inestabilidade da cadeira ou lesão do ligamento redondo, e os dolores posteriores podem ser impactos posteriores ou isquiofemorales, que não são muito comuns, na verdade. Avaliar os músculos, todos os músculos, os grupos musculares em todas as amplitudes e os músculos isoladamente. Temos que fazer alguns testes diagnósticos diferenciais em las dolores anteriores e las pubalgias, fazer o teste de Grava modificado, e nas dolores posteriores sempre avaliar los dolores del nervio ciático, tenemos que hacer los testes de contractura de piriforme, los testes de irritación ciática y de la síndrome del piriforme. E quando temos uma anamnese positiva, um paciente com dor articular relacionado à mobilidade, relacionado a desportes, pero examinamos ao paciente e não temos nada. Temos que entender que alguns pacientes têm anatomia normal, pero em alguns movimentos, como as bailarinas, conseguem chegar a uma amplitude de mobilidade grande e causam um pensamento dinâmico. E também que pacientes em alguns desportes muito específicos, como os corredores de maratonas, devido à biomecânica do movimento, podem ter dolor em certos passos específicos de sua modalidade. E se tienes dúvida, sempre use esta ferramenta, o teste diagnóstico. Ele pode ser feito com ultrassom, com tomografia ou com radioscopia, onde tem uma dor atípica, um caso que se tem dúvida se a dor é da cadeira ou se é do neuromuscular, pode usar o anestésico associado ao corticoide para melhorar sua acurácia do diagnóstico e seu tratamento. Mensagem: sempre tem uma rotina, sempre avalie a idade, se é mulher ou homem, as queixas de fatores de pior e melhora. Procurem o sítio da dor e se teste o positivo para que está pensando, e na dúvida sempre hagam o teste, a prova diagnóstica. Gracias. Perdão por mi portunhol, estou tentando falar como para facilitar um pouco. E nesta charla eu quero apresentar um pouco da relação de o que venimos em exames de imagem, em la artroscopia de cadera, em los pinçamento femoroacetabular, e o que miramos em la cirurgia, tentar correlacionar o que miramos em la raio-x e o que temos que corrigir em la artroscopia de cadera. Então, os objetivos são compreender e relacionar as alterações de imagem, especialmente essas, em artroscopia de cadera e no pinçamento femoroacetabular. Minha rotina em todos os pacientes de cadera jovem são pedir AP de quadril completo, uma radiografia de perfil de cadera em las 3 posições, de 1,45, de 1,90 e Lequesne. Eu sempre hago uma ressonância de cadera unilateral comparativa, porque temos que ter como base a cadeira contralateral. Em todos os pacientes que eu vou fazer cirurgia, eu faço uma tomografia de cadeira com o protocolo de impacto. O que é isto? Em pacientes que têm que fazer cirurgia, eu uso a tomografia para mirar as versões do coelho e algumas deformidades que não são visíveis em exames em 2 dimensões. Então, el pincer, em la alteração morfológica do acetábulo, temos que compreender que... Quando miramos isto em la radiografia, temos uma tomografia e temos uma imagem igual em la artroscopia. Então, a primeira coisa no pincer é entender, e eu ponei todos os slides de cadeiras direitas para ficar um pouco mais compreensível. Temos que entender a ubicação anatômica, onde estamos falando, onde estamos mirando. Então, dividimos a cadeira em um relógio, e as 12 horas são na posição mais anterior possível. Então, este é um caso de um pincer focal, é um pincer muito comum, onde miramos cruzamento pequeno na região anterolateral, e o que miramos em artroscopia, a deformidade um pouco mais saliente, e depois a radiografia mirando não há mais cruzamento e a correção. Então, na verdade, temos que compreender que a alteração óssea é muito relacionada com a anatomia que vamos a mirar. Temos que entender onde é a deformidade, se é anterior, se é lateral, se é posterior, e é a mesma coisa que vamos a mirar na cirurgia. Esse é um caso de um pincer complexo, um pincer mais global. Miramos a alteração anterior, lateral e posterior. Conseguimos mirar a tomografia e a imagem da cirurgia. E aqui temos a artroscopia mostrando toda a calcificação do labrum, o labrum calcificado na grande projeção do acetábulo sobre a cabeça. E depois da correção, miramos um labrum que ficou degenerado e instável, mas não há mais a deformidade óssea. Aqui as radiografias e a tomografia comparativa de meus pacientes com a correção da sobrecobertura global. Esse é o pincer mais comum em todos os casos sintomáticos, se chama subespinhal. A verdade é que é uma proeminência, uma inserção mais baixa da espinha ilíaca anteroinferior, que miramos na radiografia essa posição como uma circunferência pequena. A tomografia mostra essa implantação baixa e vemos que não é uma alteração muito saliente, sim solamente uma falta de concavidade. E a correção óssea nos traz uma parede reta e côncava. Um caso muito típico, com impacto subespinhal, com a calcificação do labrum. Toda vez que na cadeira de adulto se mira uma calcificação do labrum, isso mostra um labrum danificado. Isto é sinal de uma patologia crônica, onde há uma lesão do labrum que se calcificou com muito tempo, muito indicativa do pinçamento tipo pincer. Então aqui está a imagem da calcificação e depois da ressecção da calcificação na estrutura do labrum para reparo. Eu falo muito desse pincer do labrum. Toda vez que há a ser um tratamento artroscópico das lesões de labrum na cadeira, teremos que otimizar a cicatrização. O labrum tem uma cicatrização que vem de acetábulo superior e não intraarticular. Então, em todos os casos que temos que fazer um reparo da lesão labral, temos que cruentizar o acetábulo, mesmo que não haja pincer. Então, eu hago sempre esta pequena correção na borda labral superior para estimular a cicatrização do reparo labral, como está aqui. E uns conselhos muito práticos sobre o pincer, ok? Cada correção de 1 milímetro equivale a 1 a 2 graus em ângulo CE. Então, não podemos corrigir demais, não podemos criar um quadril inestável com uma displasia. O parâmetro radiológico não é bueno, a radioscopia não funciona, as imagens intraoperatórias são difíceis. Usem o BUR. O BUR tem de 4 a 5 milímetros, dependendo de cada empresa. A verdade é que nunca ressequem mais de um BUR de extensão. 5 milímetros são hasta 10 graus. 10 graus na estabilidade de cadeira é muito importante. Então, cuidado com isto. O pincer sempre saque menos hueso do que mais osso e, se necessário, pode compensar isso em fêmur, em CAM. Essa é uma coisa muito importante e fácil de ser feita. O CAM, a principal deformidade que sabemos que causa lesões de cartilagem, lesões de labrum, artrose de cadeira em pacientes abaixo de 60 anos. Este é o principal objetivo da cirurgia para tratamento do pinçamento femoroacetabular. São descrito como essa deformidade em cabo de pistola, um came grande, lá aqui está o mesmo caso, a tomografia e a imagem quirúrgica. E como o pincer, temos que entender onde é a deformidade, se a deformidade é anterior, se é lateral, se é anterolateral, para entender onde temos que corrigir. Mira, este é um caso que tem CAM em las 3 posições, tem CAM lateral em la P de cadeira, tem CAM anterolateral em la DUM 45 e também tem CAM anterior em la DUM 90. Então, temos uma correção extensa de anterior hasta lateral da cadeira e também podemos dividir a coelho femoral em um relógio para entender e otimizar as publicações. Esse é um caso de um CAM lateral, mira a radioscopia pré-ressecção, onde veremos um CAM grande lateral, e o que veremos na imagem abaixo, que é quase um cogumelo, como dissemos na cadeira, e depois da correção, o offset restabelecido. Em CAM, me gusta planejar quanto eu quero corrigir. A verdade é que é importante ter 8 a 10 milímetros de offset para termos uma grande amplitude de mobilidade. E também podemos usar a parte não está funcionando, a parte de baixo do cuello, podemos mimetizar a curva de parte posterior inferior para a parte anterior, para buscar quanto queremos corrigir. Então, para fazer o came, necessitamos venir o que estamos fazendo, temos que fazer capsulotomia, temos que fazer uma capsulotomia necessária, conforme precisamos corrigir. Cames grandes são pacientes que demandam capsulotomia maior, cames pequenos, capsulotomias menores. Eu sempre empiezo lá resseccionando a parte proximal, e eu hago uma marcação com o albur de 5 milímetros de profundidade, e depois vou seguindo com uma rampa hasta a base do cuello. Isso dá na média 8 a 10 milímetros de correção. Depois, é preciso, importante olhar a radioscopia para ver se está correto e a quantidade necessária. Então, essa é uma imagem comum na radiografia API perfil. Eu sempre hago uma prova operatória. Mira, esse paciente teve uma grande correção, mas há um impacto residual anterior. Então, quando eu fui mirar, precisava corrigir um pouco mais na cadeira anterior. Então, temos que fazer a prova, porque o que miramos às vezes não é exatamente o que estamos corrigindo e quanto o paciente necessita de correção para a mobilidade. Cuidado com a falta de correção do cuello femoral na base, porque uma das principais causas de revisão é a falta de correção na base do cuello femoral. E se tienes que fazer uma capsulotomia maior, ok, depois pode cerrar a cápsula, que tem excelentes resultados e baixíssimos casos de instabilidade de cadeira. As complicações de cames são grandes, não se pode fazer isso, não se pode sacar mais de 30% do cuello ou 110 grados. A verdade é que temos que sacar até 10 milímetros, não mais que isso, para evitar as fraturas. E também temos que cuidar com a came residual. Se não sacarmos todo o impacto, principalmente na base do cuello, vamos a ter falha de artroscopia. Então, lembrem, tem que fazer capsulotomia, tem que ter um offset adequado, teremos que usar a radioscopia e sacar o cuello até o final. Tá bem? Este é um caso demonstrativo, um paciente homem com pensamento femoroacetabular misto. Mirem lá, pequeno cruzamento, al came lateral, came anterolateral e came anterior, onde foi feita uma planificação, uma correção da deformidade tipo pincer, foi feita a correção da deformidade anterior, lateral e anterolateral da cadeira, e a comparação das radiografias com a correção óssea, tanto da parte acetabular quanto da parte femoral adequada. Então, lembrem, teremos que entender a anatomia para entender o exame físico, para entender o que vamos a mirar na artroscópia de cadeira e onde temos que corrigir. No pincer, sempre menos correção é sempre melhor, porque hasta 3% das pincers são causadoras de sintomas de artrose. Então, não compreendemos exatamente se necessitamos corrigir tanto. E a complicação da correção excessiva é muito grave com instabilidade. E lá temos, o paciente nos chega ao consultório para correção do que todos os outros colegas conseguem mirar, que é o CAM. E temos que corrigir. Então, temos que corrigir em todas as áreas, temos que fazer a prova operatória, restaurar o offset para que você para ter a mobilidade adequada e a correção do pensamento. Gracias. E para encerrar minha charla, talvez a charla que a mais me gusta falar, porque temos uma visão que a artroscopia de cadeira é um procedimento muito difícil, demorado, que tem uma curva de aprendizagem muito longa, mas a verdade é que quando eu comecei em 2009, eu tive que fazer tudo solo. não tinha instruções, não teria alguém para me ajudar, não tinha ninguém para dar dicas práticas. E me gusta muito essa parte, porque quanto mais pessoas puderem fazer o procedimento com qualidade, mais vamos a crescer juntos com as cirurgias preservadoras. Então, temos estes problemas em todos os que estão começando. O tempo cirúrgico, que muitos que começam têm 4 ou 5 horas de cirurgia. Uma cirurgia artroscópica não pode durar mais que 2 horas em um caso de qualquer articulação, num caso comum. Todas as cirurgias em um profissional treinado são cirurgias de 60 a 90 minutos. Temos também que as taxas de complicações iniciais são muito grandes comparadas com os cirurgianos que têm mais experiência. E também porque temos o risco, o paciente nos procura porque quer tratar a dor, mas também porque quer reduzir o risco de atrofiia total de cadeira. E a verdade é que se não sabemos fazer a cirurgia e melhor, não sabemos selecionar os pacientes perfeitos para serem operados, não vamos trabalhar na redução do risco. Então, como fazer isso? Temos que ter capacitação, temos que saber selecionar os pacientes que devemos e, mais importante, os que não devemos operar. Temos que ter uma boa técnica cirúrgica, temos que entender como não ter complicações devastadoras e como mirar o que estamos fazendo. Então, agora temos diversos cursos em todo o mundo. A Ana tem vários cursos de iniciação de artroscopia em geral e também de artroscopia de cadeira. Temos a Sociedade Internacional de Artroscopia de Cadeira Xiii, que tem meetings anuais e vários cursos. E também temos agora na Sociedade Brasileira de Cadeira diversos cursos. Este ano teremos 2 cursos especialmente sobre a cirurgia preservadora, com um treinamento prático em modelos que pode ajudar muito, e também podemos fazer visitas com diversos colegas no mundo para aprender. A seleção do paciente começa no consultório, e os grandes problemas da artroscopia de cadeira acontecem quando se faz cirurgia em quem não se pode fazer cirurgia. E todos, quando começamos com este caso. Um homem que tem 40, 45 anos, que tem dor típica, que tem uma restrição de mobilidade e tem um teste positivo. Esse é o paciente que miramos ser ideal. Mas quando miramos com um pouco mais de cautela, a idade acima de... Iniciamos com 50, agora 45, 42, eu creio que os pacientes ideais têm menos de 35 anos, que têm muita musculatura, são muito fortes e que têm uma restrição de mobilidade significativa, são pacientes problemas, porque a cirurgia é muito mais difícil para começar. Este paciente vai ter essas radiografias, que por definição não temos contraindicação da artroscopia de cadeira, pois todos nós sabemos que também não temos bons resultados, porque a cirurgia é difícil, porque o paciente não tem pinçamento, o paciente tem artrose da cadeira, ok? Então, tem que entender que a artroscópia de cadeira para pinçamento não é a mesma coisa que para artroses. A cirurgia é mais difícil, os resultados não são buenos após 2 a 3 anos. Estas imagens da ressonância mostrando grandes lesões condrales, degeneração labral e pinçamento são muito difíceis de tratar. Vai fazer a cirurgia e o paciente com 1 a 2 anos vai volver a ter sintomas e não vai se quedar satisfeito. Por outro lado, esse é o paciente para se ter muito cuidado. Uma mulher que tem uma profissão com um desporte de alta mobilidade, que tem uma queixa de dolor, sim, pero de desacoplamento da cadeira, com uma hipermobilidade global, que tem testes de dolor articular positivo, sim, pero também tem testes de instabilidade de cadeira e tem os critérios de Beighton positivo. São pacientes que, quando miramos com mais cautela, têm todos os sinais da cadeira inestável, que podemos mirar a alteração de pinçamento em las imagens, ter dolor, é um paciente jovem, pero não é um paciente de pinçamento, e sim um paciente com alto risco de instabilidade. Miramos essa radiografia, onde vimos um coelho valgo, uma displasia borderline, E quando hacemos a tomografia, que é muito importante, especialmente em pacientes de hipermobilidade, miramos que são pacientes que têm muita anteversão do colo femoral. Mira, 41 ou 48 graus são sinais de gravíssima anteversão. Porém, eles têm CAM, eles têm falta de curvatura anterolateral. Isto não é um CAM, é uma morfologia alterada da displasia de cadeira. Então, não podemos tratar o CAM em pacientes inestáveis. Estas são imagens sugestivas em la ressonância de pacientes com inestabilidade. Um ligamento redondo muito largo e ascendido com uma fóvea muito superior e uma lesão labral ou um sulco labral anterior muito proeminente. Cuidado com esses pacientes que vêm na radiografia com CAM, uma displasia que não é muito fácil de ser medida na radiografia, uma ressonância mostrando lesão de ligamento redondo e lesão labral anterior. Estes pacientes são inestáveis. Estas são as grandes complicações da artroscopia de cadeira. E na técnica cirúrgica, temos em artroscopia de cadeira dois métodos, duas maneiras de fazer a mesma cirurgia, e eu creio que temos que saber fazer ambas. Os colegas que fazem artroscopia de cadeira outside in têm que saber fazer em casos mais inestáveis o inside out. A porcentagem são em torno de 5%. Os colegas que fazem inside out também têm que saber fazer outside in. Por quê? Porque nas cadeiras mais rígidas, 15 a 20% temos uma dificuldade de tração. Então, vamos fazer as lesões iatrogênicas se não tivermos a técnica outside in associada. É a mesma cirurgia, porém a capsulotomia outside in, ela tem menor risco de lesão iatrogênica da cadeira, do cartílago e do labrum, porém, tem que fazer uma capsulotomia maior. E uma grande vantagem, não precisamos começar com tração. É muito mais fácil fazer tração com capsulotomia hecha. Lá em inside out, a capsulotomia pode ser melhor, pode ser só interportal, e nos casos de inestabilidade, podemos fazer assim. Porém, necessitamos de um paciente com mais mobilidade, com tração inicial. O pincer sempre entender, saber onde estamos corrigindo e corrigir pouco. Ele CAM sempre fazer a planificação e sempre mirar com a radioscopia o que teremos que corrigir. Como eu disse em outra aula, não podemos ressecar pouco, porém também não podemos ressecar muito. Teremos que proteger os pacientes, sugiro usar botas de proteção dos pés, porque a tração é em torno, inicialmente se usa 40 a 50 minutos, hoje eu uso 10 a 15 minutos de tração, mas não podemos ter as complicações vasculares. Teremos que proteger o períneo, temos que proteger os braços dos pacientes e temos que usar os portales para nos ajudar. Eu uso em todas as minhas artroscopias 3 portales. É o portal anterolateral, 1 a 1,5 centímetro proximal, e use a radioscopia, como eu mostrei aí, para marcar a direção em la piel, em la radioscopia, para entender seu principal portal. Depois, eu uso o portal médio anterior, é uma medida que varia um pouco, porém, esta marcação da ponta do quinto dedo com a articulação proximal da segunda metacarpofalangiana é uma boa medida para pacientes que não têm uma grande deformidade. E sempre uso o portal anterolateral distal para fazer as correções do labrum, as correções do pincer anterior, e a verdade é que é um triângulo mais ou menos equilátero em relação aos dois portales principais. A tração da cadeira não é força e sim técnica. A tração da cadeira não demanda mais do que o peso do corpo para tensionar, porque o vetor tem que ser lateral e não distal. Então, teremos que usar mesas de trações adequadas, e me gusta muito o poste com offset lateralizado e o panetone muito grande para fazer a pressão lateral. Teremos que apenas tracionar com o peso do corpo e na abdução de 30 graus com a tração contralateral e depois fazer a adução contra o poste. A tração, a força não é no períneo e sim na parte imediata da coxa. Essa é a imagem que temos que fazer. E o que vamos mirar em artroscópia quando a cadeira se está abrindo. Não uso mais força do que o peso do corpo. Se não está adequado, Tiene que volver, tracionar al lado contralateral y hacer una aducción contra resistência. E se não conseguimos mirar a cirurgia, entramos, está sangrando, a cirurgia de la bola roja, teremos que cuidar com a anestesia. O principal parâmetro é que a pressão arterial média tem que estar abaixo da pressão da bomba. Eu sempre uso a anestesia raquidiana associada na geral para melhor conforto do paciente, e eu uso o transamin de 10 a 30 miligramas quilo durante o pré-operatório. Sempre cauterizar os fatos, como a cirurgia aberta. Teremos que usar instrumentos adequados, como as camisas de alto fluxo para aumentar a circulação do suero. E eu uso em todos os meus casos 5 miligramas por litro de adrenalina. Não há problema de usar em 5 litros, 10 litros. Já usei 90 litros. Então não vamos ter problemas com adrenalina. E a bomba de infusão tem que estar no mesmo nível do coração do paciente. Isso é muito importante. Então, como mensagens, sempre façam treinamento, aprendam a selecionar os que devemos e principalmente os que não devemos operar. Temos que ter uma técnica cirúrgica adequada com capacitação. A tração é com o vetor lateral e não distal. E temos que ter uma boa campo de imagem com o controle com anestesia e a bomba de infusão. Muitas graças mais uma vez. Essas são minhas paixões, minha família e a pesca. Estou muito honrado pela invitação e espero volver em breve. Grato.
Agradecemos al doctor Fuchs y vamos a modificar el rol. Vamos a hacer 2 charlas seguidas. El doctor John Kennedy, que viene de Estados Unidos, es profesor de cirugía ortopédica de la Universidad de Nueva York, jefe de división de cirugía y pie y tobillo en el Hospital de Nueva York, instructor máster de la ANA, de AOFAS, miembro de la AOFAS, de la AOS, de la ESCA y de la AFAS. Él hará 2 charlas seguidas, conceptos actuales en artroscopía anterior y repensando lesiones de cartílago en el tobillo, cómo hacerlo bien. Adelante, doctor Kennedy.
Thank you very much. I'd like to, first of all, thank CCAP, Dr. Suarez, and of course Miriam for organizing this and inviting me here today. I'm going to talk a little bit about ankle arthroscopy, and I realize there is some overlap between Dr. Martin's talk and my own, but we'll spin through this fairly quickly. These are my disclosures, and this is our agenda. So the first ankle arthroscopy was actually performed in my alma mater, NYU, in New York back in the early 1930s, but it wasn't popularized in the 1970s and 80s in Japan. And certainly, if you look at the evolution of arthroscopy, where we're now doing in-office nanoarthroscopy, in the last 20 or 30 years, it's certainly evolved a great deal. We're going to talk about anterior ankle impingement, which is very common, very similar to the CAM lesions that we heard. They're just talking about in terms of the hip. Anterior impingement, anteromedial impingement, anterolateral impingement. So anteromedial impingement of the ankle joint is typically from a direct trauma resulting into this microattritional injury to the front of the joint, and you may get either soft tissue or bony impingement on the medial side of the ankle. It was first described as football. Where I come from, football is soccer, and I know that's a very popular sport here. So it was first described as footballer's ankle back in the 1950s, and again it was an attritional injury from striking the soccer ball. At that time they thought it was from a capsular injury, probably isn't, because the capsule is a little higher than where we typically see these osteophytes. Patients typically present with pain. They may have a history of recurrent instability, and particularly pain on forced dorsiflexion. But we really diagnose it with a simple x-ray, and Nick Van Dyke showed us this x-ray, and it's an oblique view or slightly oblique view with the foot in external rotation. And that shows up, you can see on the lateral, standard lateral, you won't see a lot of this impingement, but this oblique view, you'll see the impingement very nicely. So many years ago, before we had ankle arthroscopy, we had to open these, and of course when you open them, you run the risk of infection, long recovery times, and so forth. So part of my practice as a sports physician in foot and ankle surgery is to do a lot of ankle arthroscopy on anteromedial impingement. We use standard anterior portals, which is an anterior medial and anterolateral portal, and we put patients in traction. The superficial perineal nerve, as you know, is at risk, so we have to map that out. We use a fourth toe flexion sign where we flex the fourth toe, and then you will see the SBN far more easily, and that is marked out with a marking pen before we perform the operation. This is an anteromedial impingement. This is a patient, in fact, who has some arthritic changes, but it's the same. We take away some of that anterior deltoid and a lot of the bony overhang, and you can see there's a large space now available in that anteromedial impingement. Everything we'll talk about today is based on data, because I can say anything I like, but unless I back it up with data, it's meaningless. So this was our first look at our anterior impingement about 12 years ago. We had 41 patients. Most of these were sports people, and you can see that 93% patient satisfaction. So if you're doing an operation that's over 90% patient satisfaction, you're doing the right operation. So this is very easy for patients to recover. But we also looked at this with our colleagues in AMC in Amsterdam with Nick van Dijk's group, and we looked at 20 studies, low complication rate, and again we showed what we found in our own study, that the likelihood of success is over 90%, and really complications are very low. A recent interesting study by one of our previous fellows who's now working at Harvard, Ariana Giannakis, showed that gender plays a role in this. So there's a likelihood in a female athlete will have a greater likelihood of developing anteromedial impingement, and the likelihood of success is slightly lower in that population. So that was an interesting gender-based study. Now, anterolateral impingement, by contrast, is oftentimes associated with soft tissue rather than bony impingement. And the soft tissue injury here is Bassett's ligament or Furkel's band. It used to be believed that this anterior band of tissue, which is the anterior part of the AITFL, was a pathological ligament, that it was an accessory ligament. Some really elegant work by Pau Galano, the late great Pau Galano, showed that in fact this ligament is there in all of us, and it just simply becomes hypertrophic or scarred over time, particularly in patients with lateral ankle instability. And that causes a snapping of the band over the lateral border of the talus. So that's anterolateral impingement, and again, it's perfect for arthroscopic resection. The clinical presentation on that is, again, the patients will feel this snapping band on the lateral aspect of their foot or ankle. Can be seen with both T1 and T2 weighted imaging, where we see the band, but we also see a large amount of cicatrized tissue and inflamed synovium around there. And this again is another arthritic patient, and you can see we're resecting away this hypertrophic band and then Bassett's ligament. We clean that right back. You actually can remove it in its entirety, it has no roll, and then we resect the osteophyte. So I'm going to talk very briefly about posterior ankle impingement, because I know Javier is going to talk about that as well. Posterior ankle impingement is typically for patients with an ostrigonum or an inflamed FHL ligament or a Stida process. All of these are secondary centers of ossification at the posterior aspect of the talus, and when the patient or athlete is involved in a plantar flexion injury, they'll have impingement. The FHL is our landmark. We look for that always, because in front of that we know we have a neurovascular bundle that we need to be aware of. So this is posterior arthroscopy, originally described by Nick van Dijk, again from the AMC group, and since then we've certainly expanded on its role. These are the portals. We typically use just a two-portal technique, posterolateral and posteromedial. You have to be careful in the posteromedial aspect that you don't go into any of this neurovascular bundle. So we always aim to hit the bone first and then withdraw, so we don't involve any of the soft tissue, the critical structures in the soft tissue. So again, we've done a systematic four-stage approach to this, and just like Furkel did in the ankle, the anterior ankle, we've done the same thing in the posterior ankle, and we look at this in 4 quadrants: supralateral, supramedial, and we go counterclockwise. So, and that is defined by a horizontal line from the intermalleolar ligament. So supralateral, we're seeing the posterior syndesmotic ligaments. Supramedial, we're seeing the FHL, and inframedial, we're seeing the ostrigonum, which is one of the things that we typically look for here. So this is a very simple, there's the ostrigonum, and there's the FHL, and there's your intermalleolar ligament. And you can see that the FHL is getting caught up by this transverse ligament, or the intermalleolar ligament, and the ostrigonum, so we'll take both of those away. When we started with posterior arthroscopy, we took everything. We wanted to make this looking like an anatomic dissection. We realized that you don't need to do that any longer, and perhaps it could do more harm than good because it can scar. So now we leave most of the fat that's back there that can obstruct your vision, we remove that. And you can really go down into the FHL and look at that all the way right around into the medial malleolus. So then again, everything we do needs to be data-driven. What's the outcome of posterior arthroscopy? Well, we looked at 22 patients with a 2-year follow-up, and again, the scores in that, both the typical MOCART scoring in that and the SF12 and FAOS were very encouraging in our own group. We looked at this again with the AMC group in a large combined center review, and again, results of this were excellent. Over 90% of patients got back to their previous level of sport. So this was a study by James Calder, and he looked at those patients who had posterior ankle arthroscopy for posterior impingement. And again, this is why it's important, because if you look at the traditional open method, since people still do the open method, it's not a wrong surgery, but if you're looking for an elite athlete to get back to return to play in a short period of time, posterior arthroscopy is the right way to go. And James worked with us on this paper, and again, in professional athletes, this is the way to go. This is a nice paper out of Greece, which is just looking endoscopic or arthroscopic removal versus traditional open removal. And you can see the return to play is roughly 6 to 7 weeks, where it's twice or 3 times that in the open group. So again, underscoring the role of arthroscopy. So this is a very quick talk, so I think really arthroscopy about the ankle is diagnostic and often therapeutic. Anteromedial impingement, anterolateral impingement, and posterior impingement are best treated with arthroscopy at this point. And this is going to lead into a talk later on where I'm going to be talking about nanoarthroscopy. All of this was done in an operating room with the patient anesthetized. We now have the ability to use a needle arthroscope, a 2mm arthroscope, where we can do all of these procedures. We can do them in the office when the patient is awake and communicating with us, and we're both looking at the screen at the same time. The advantage to that is it's exactly the same procedure we're doing in the operating room with smaller instruments. So the ability to see has now been augmented with the ability to do in a very nano fashion. So that has improved patient outcomes. Okay, so that's the first talk, and I think we're going to move straight on into the second talk. I'll ask Hugo. Hugo is our fellow. That's the reason I'm here in Peru and loving my time here. Hugo came from here to NYU. He's a Peruvian resident. He's finished his residency and he's doing a fellowship at NYU. So we want to open up that pipeline between Lima and New York City because we're so happy with the way Hugo has worked in the last year and a half. So we talked a little bit about what we can do with anterior arthroscopy. One of the big things that I look after in athletes is osteochondral lesions and the role of biologics. Traditionally, we used to use microfracture for everything. Now we know that microfracture is the wrong thing to do, so we need to look at biologically augmenting chondral repair. And again, these are my disclosures. So one of the things I thought I'd show you first, which is fun to do, we do a lot of work with Cornell University and their equine department, or the veterinary department. And this was a study we looked at, looking at bovine cartilage. And this little force impactor represents what happens at the time of an ankle sprain. So you can see in this lower confocal imaging here that these cells die within 90 minutes of being impacted. So if you think about that, what happens? All of us in this room at some point have injured our ankles. The problem is that our cartilage doesn't recover. And if we get a standard x-ray, we're not going to see what's going on with our cartilage. And we know we don't have the metalloproteinase in our ankle for developing idiopathic arthritis. The only way any of us are going to develop arthritis is either from a rheumatoid condition or from trauma. So the amount of injury that we have to our cartilage is really, really important. And so when you look at this is a nice work done by Lisa Fortier and Kira Novakoski, and it shows here with multiphoton microscopy that when you have this initial insult, you get cell apoptosis, cell necrosis, and they die, and then there's a regenerative capacity. And we think, well, that's great. They regenerate to normal chondrocytes. They don't. What they regenerate into a type of fibrocartilage, which will never be normal, and that is the precursor to arthritis. What's even more alarming is that when you hand your scope to the resident to say, have a look around the ankle joint or the knee joint, look what happens. This is the first 500 angstroms or 500 nanometers of cartilage. 90% of your shear forces go through that tiny little layer there. The problem is if you damage that, it will never go back to normal. So be careful handing your scope over, because the iatrogenic injury is common, and if we just have a little scuff and think, oh, that'll fill in, well, it will, but it'll never fill in with normal cartilage, and you'll set that patient up for arthritic change downstream. And we know all that work from work that was done by Mel Glimcher, my old boss up in Harvard, and Fred Shapiro. Back in the 80s, they looked at to see what happens when you injure cartilage. Well, it never regenerates. It goes through this process where you do get originally type 2 cartilage filled in, but then it dedifferentiates over time to type 1, and that ultimately fails. So cartilage is really important. And the reason it's important is it just doesn't have the capacity to regenerate itself. So that's where we come in. We have to come up with strategies for filling in cartilage defects. And there's two basic ways that we can do this. We can either try and repair it, or we can try and replace it. And we'll talk about biological adjuncts to this. And we're going to talk about concentrated bone marrow aspirate, platelet-rich plasma, hyaluronic acid, and micronized adipose tissue. In the United States at the moment, in my city alone, in New York City, there are 700 regenerative centers that are advertising stem cell therapies for cartilage wear and tear. 700. Less than 10 of those have any academic credibility. So this is an area, there's a lot of people who are claiming a lot of things, and we have to really be careful how we use it. Because when you have a hammer, everything will look like a nail. And all of these regenerative biologics, they can't be used always, and they certainly don't repair cartilage. You know, when I was coming down on the plane, there was an advert in the back of the seat in front of me about a knee. You don't need a knee replacement, you just need an injection of these stem cells. And you saw the patient had an x-ray where they had no cartilage, and suddenly they had all this cartilage. None of that is true. All we can do with biologics is try to preserve cartilage. We cannot regenerate wholesale cartilage, and I'll go into that in a little bit. So our job as physicians is to listen to others, figure out what's the best for our patients, but don't believe everything you hear, because biologics are great, but it's not a magic wand. So concentrated bone marrow aspirate. Concentrated bone marrow aspirate has many things in it. It has stem cells, it has growth factors, and it has a very powerful anti-inflammatory, this thing called interleukin receptor antagonist protein, or IRAP. And that is our own best defense against inflammation. It reduces the interleukin receptor 1 beta. The number of stem cells is very, very small. It's less than 1%. Most of the active factors in concentrated bone marrow are growth factors. So we used to think that stem cells, if you put a stem cell from bone into cartilage, it would make cartilage. If you put it on skin, it would make skin, and so forth. The problem with that is, if you actually look to see where those stem cells are a day later, less than 0.1 of them are round. So what happens to stem cells? It's a very different theory now. So when you inject a stem cell, an activated macrophage, remember like those Pac-Man, they're those little cells of white cells, they come along and they engulf that stem cell. That then produces a secretome. And this is things that you're going to learn about, because we're learning about it in New York right now, and I know you guys are learning about it here. Secretomes can be marketed by industry. We can't sell you stem cells, but we can sell secretomes, or industry can sell secretomes. And secretomes are going to be these biological packets that will push parts of the body to regenerate and replace themselves. So it's important. So what you do is you have the stem cells are engulfed by macrophages, and then you have these trophic effects. Sorry, we'll go back to that slide. These trophic effects are immunomodulation. That's the most important thing. So you inject it into an ankle or into a knee, it'll turn off the inflammatory cascade. It will recruit stem cells from the local area to regenerate and repair and protect. So it's an immunomodulatory and chondroprotective is really what these stem cells do. Again, Dr. Fortier's group looked at this in horses, chondral defects in horses, and they showed that using concentrated bone marrow aspirate produced better quality and quantity of cartilage. Similarly, in Saw and his group looked at it in goats and saw the same thing. This is how we take it. We take an aspirate using a Xiii needle from the anterior iliac spine at the time of surgery. We put it into a centrifuge, which separates the different cells. Everything we do needs to be evidence-based, both based in basic science and clinical science. This was a study we did early on. looking at concentrated bone marrow aspirate with bone marrow stimulation or bone marrow stimulation alone, and we saw that the early functional results were roughly equivalent. However, looking at T2 mapping, which is this qualitative MRI, we can see the quality of the cartilage regenerative using concentrated bone marrow aspirate was far better. We also looked at in oats. We do a lot of osteochondral autograft transplants. We looked to see whether concentrated bone marrow aspirate was going to improve that. When you take a graft and put it in, always around that interface, there is some cell death. We wanted to improve that and reduce cystic formation, and when we used concentrated bone marrow aspirate, we saw that that occurred. It increases the rate at which that graft becomes incorporated. We also use scaffolds. When we use bone marrow stimulation, we use scaffolds. And in the scaffold, we put concentrated bone marrow aspirate. And again, we found functional results were similar at early time follow-up, but T2 mapping was different. Concentrated bone marrow aspirate is useful. And again, this is using the scaffold and the concentrated bone marrow aspirate with oats. Again, we've seen that the results are superior with chondral mapping. So that's concentrated bone marrow aspirate. Remember, we're always asked, what's the difference between that and PRP? The difference is it has a large amount of IRAP and it has stem cells. PRP, by contrast, we take from peripheral blood, and that just has mostly growth factors. So it has an enormous number of this TGF-beta superfamily, these cells which are responsible for regeneration and repair. And you can see that when we use this, again, in basic science model, this was a nice work done by Yuichi Yasui, who was from Japan, who worked with us for a while, and he looked at it in a rabbit model to see whether it was going to improve lesions with microfracture in a rabbit model. He found that it was. Again, you'll find doctors who will use PRP and said, okay, you need 10 PRP injections. No, you don't. You need 1. It's like, I come from Ireland originally, where we drink a lot of tea. 1 teaspoon of sugar is good, 10 is not so good in your tea. Same thing with PRP. 1 PRP is good, 10 is not better. And we've proven that in a basic science model. So we also looked at it with bone marrow stimulation. When we look at, when we do bone marrow stimulation, we don't do microfracture anymore, just bone marrow stimulation. We looked at BMS alone versus BMS with PRP, and the results were improved with those patients treated with PRP. We also want to look, what does it look like when we use PRP with an oats model? Is it as good as when we use concentrated bone marrow aspirate? And again, a nice study done by Neil Smythe, who worked with us out in Miami. Again, he showed in a basic science model that when you use PRP with oats, it improves integration and improves cartilage scoring. The problem is when you have a drug, if we were to come up with a drug today amongst all of us, and we were to present it to the FDA and say, this is our drug, we come up with a standard formulation and a standard dose. Can't do that with PRP, because everybody in this room will make a different PRP. And then if we took everybody later on tonight after we'd had a few drinks, we'd all be producing different PRP. And some of us won't produce PRP at all. So it's very difficult to conduct really good trials unless you have huge numbers to see what the true effectiveness of PRP is. And this is a very nice study here showing that there is many things: exercise, non-steroidal anti-inflammatory, smoking, platelet handling, nutrition. Exercise is one of the most important things, because if you pre-exercise, your PRP levels will go up. And that's why WADA banned PRP initially, because they thought it was a performance-enhancing drug. They have subsequently reduced that banning or taken it away. So again, anytime we review papers for publication, PRP has to be standardized. We need to know what type of PRP we're administrating, and this is very difficult in regenerative medicine to do that, or at least we're trying to make an effort to standardize what patients or what investigators are using in patients so we can standardize the outcomes. Now finally, or not finally, but we'll talk about hyaluronic acid. HA is a carboprotein that we inject. We do a lot of this in patients who have early degenerative changes. Restores the viscoelasticity and stimulation of chondrocytes. It's also a very potent anti-inflammatory, and it reduces this metalloproteinase 13. 13 is an unlucky number. It's a bad metalloproteinase. It does a lot of destruction in and around the joint, and if you inject HA, it'll reduce that, and again, it's chondroprotective. So this was a nice study done by our institution, Eric Strauss, and he looked at the effect of HA microfracture techniques in articular cartilage, again looking at a rabbit model that we previously used, and he showed that greater infill with HA, and again, chondroprotective and anti-inflammatory. It doesn't necessarily produce lots of new cartilage, but it will protect what you have. This was a study done out of China, 35 patients, HA with bone marrow stimulation, and bone marrow stimulation again, showing that HA is useful. The time to inject this is variable. Typically, we don't inject it after arthroscopy because there's still a lot of fluid in the joint, and so we wait a week later, and then we inject it when they come back to the clinic. So finally, we'll go into micronose adipose tissue, or MAT. This is fat cells. When I tell patients I'm going to take fat from them and inject it into the ankle joint or knee joint, they're very excited because they think it's liposuction. And it truly is liposuction. All of us in this room have fat in our abdomen that we can use. We don't need a lot of it, but we do the same procedure as we would if you were in a plastic surgery office. We use long needles, we use suction, we take out the lipoaspirate, and then we put it through a process. Now the problem is, in the United States, the FDA only allows micronized adipose tissue, which is mechanically agitated. It doesn't allow anything that's been manipulated outside the body to be re-injected. So we can't use collagenases and other substances that they're using in Korea. Nonetheless, MAT is useful, and I'll show you why. A lot of this work we have to thank Farshid Gulak, who's at that point down in Duke, to show us that fat cells have a preponderance and are driven really towards their path of differentiation of producing more chondral or cartilage-like cells. And with that knowledge, we look then to see how does it affect cartilage injuries. Well, we have adipose-derived stem cells. Again, that's taking cells from the body, regenerating them and injecting them back. Can't really do that in the United States at the moment. I'm not sure about Peru. Stromovascular fraction, which again is a fat cell-based therapy, which we take a collagenase and cleave the fat away from the extracellular matrix, and then micronized adipose tissue, which is what we are able to use. When you look at the literature, which we all have to do to decide what is best for our patients, the problem is that there's really not a lot of good data out there. It's a very heterogeneous mix of data. It's looking at those three different things, and they're really not defining what they are. So our role is to define what we're using and how we should use it. Using MAT, or mechanically agitated tissue, is slightly better, we think, than using collagenase. Collagenase destroys a lot of the extracellular matrix and destroys a lot of these pericytes. Pericytes are these almost like pre-mesenchymal stem cells that live on the vessels, and when you use collagenase, they can be lost. So I think there is some advantage to using MAT. This is what it looks like when we take it, and again, when we were doing this first, we were able to get 20 or 30 cc's of this MAT. You inject 20 or 30 cc's into an ankle joint, the patient will hate you for life because the capsule will just explode. So we have all of this, and then we only need a little bit. So for the ankle, we use about 5 cc's, and for the knee, we use about 7 cc's.
Time's over, sorry.
And so, we all right? Okay. So the adipose-derived tissue, this is how we do it. It's a suction device. Again, it's just like if you are in plastic surgery, you do exactly the same thing, harvesting, suction pulls it in, and then we wash it with these syringes, and we're left with this. There's a slide missing. We're left with what you saw earlier on, which it just looks like adipose tissue. When we look at this in the ankle OA, you can see this is a nice study here, which showed out of Italy, out of I think Verona, and it shows that again using MAT within an ankle joint, certain ankle OA, certainly is useful in terms of patient outcome and patient functional outcome and the radiological scores. I think it's important always to be very honest about your outcomes, and when we injected, we just did our first 20 patients and we published on that. It wasn't as good as I thought. When we do it in the knee, about 60 to 70% of patients get functional improvement. When we do it in the ankle, maybe 50%. But if you're in that 50%, it's a good place to be, because the alternatives in the ankle aren't great. So that's why we continue to use it, letting the patient know there's probably a 50% chance this will not work. So again, these are two MAT in the knee. This is again underscoring that the results in the knee are slightly better because cartilage in the knee is slightly different. It has different mechanical and biological properties than cartilage in the ankle. So you can't always extrapolate what you find in one joint and what you find in both. So these are a couple of cases. This is a 44-year-old male. He had pain. This is an interesting guy. How are we doing on time here? You all right? Okay. So this is a guy who did 7 marathons in 7 days in 7 continents. So he developed this small osteochondral lesion. We went in, we used an extracellular matrix with concentrated bone marrow aspirate, and then he went back to his marathon running. Problem is, he came back, and again, he needed an oats. This is an oats graft that we put in there, and you can see it's a cylindrical graft, and we put a extracellular matrix around this. And this is it afterwards, looking at a second look arthroscopy. This is a 40-year-old male, multiple traumas, progressive pain, and he worked as a commercial pilot. Looked like he had developed AVN and collapse of his talus. So for him to fly again, it was important. He was looking at an ankle fusion. You can't fly a plane with an ankle fusion or an ankle replacement. So this is what we did. You can see as AVN. So we were able to retrograde drill. We used nanoscopes. We used mechanically agitated tissue in here. And this is him walking a couple of weeks later. And his range of motion now has improved significantly, and he's back flying a plane. So they're just two cases that really kind of summarize what we do. I think biological augmentation is currently leading towards less invasive and conservative therapies to address foot and ankle pathologies. It'd be nice to have randomized controlled trials. They're difficult to do, but I do think that rather than being an optional extra to use biologics at the time of any cartilage injury, I think it's a requirement. We should be using them, and we should be using them judiciously, but we should certainly be using them. So many thanks indeed for your attention.
Thank you. Thank you, Dr. Kennedy.
Bueno, vamos a juntar 2 charlas, la técnica de indicación de artroscopía posterior con pinzamiento posterior de tobillo, dado por el doctor Javier Martín, ya conocido por nosotros, que viene desde Barcelona. Es el actual presidente electo de la Sociedad Española de Cirugía Ortopédica y miembro de la Sociedad Europea de Pie y Tobillo. Adelante, doctor Javier.
Muy bien. En primer lugar, agradecer a la Junta Directiva de la Sociedad Peruana de Artroscopía, al doctor Carreño, al doctor Zagal, al doctor Berenechea, a Luchín, buenos amigos, al doctor Jaime, ¿no? También Vázquez, ¿no? Y a los moderadores de la sesión, a José y a Óscar, por haberme invitado a participar en este congreso en este país que tanto quiero y que tanto me gusta venir, ¿no? Yo os hablaré un poco de las técnicas de artroscopía posterior de tobillo, que a partir de las publicaciones de Nick Van Dyke alrededor del año 2000 empezaron a tener una gran utilidad en nuestras manos, ¿no? Y nos ha abierto mucho las posibilidades de tratamiento en patologías de tobillo, ¿no? Pero sobre todo pensar que la técnica de artroscopía posterior tiene sus peligros, que con el abordaje posterolateral podríamos lesionar el nervio sural y la vena safena menor, poco riesgo relativamente, pero por el posteromedial hay mucho más riesgo por el paquete vasculonervioso de la tibial posterior y por el flexor alucis longus. Publicamos este trabajo que veis aquí en la imagen, ¿no? Sobre los abordajes anatómicos entre la distancia en el abordaje posterolateral y los nervios, el posterolateral con el nervio sural, y hay una distancia suficiente de seguridad, pero en el abordaje posteromedial en relación al nervio tibial posterior la distancia es de solo 7,27 milímetros en 18 especímenes que hicimos el trabajo y la publicación. Para evitar estos problemas, ¿qué técnica utilizamos cuando hacemos nuestros abordajes posteriores de tobillo? Empezamos por el abordaje posterolateral, que lo dirigimos en dirección al segundo radio y es un abordaje relativamente seguro, pero si hiciésemos lo mismo con el posteromedial, iríamos a impactar con el flexor hallucis longus y, lo que es peor, con el nervio tibial posterior. Para esto, después de haber hecho el abordaje lateral con el que introducimos la óptica, por el abordaje posteromedial introducimos los instrumentos de trabajo y, una vez superado el tendón de Aquiles, giramos nuestra mano 90 grados hasta tocar la sensación metálica de la vaina del escopio, y cuando tenemos esta sensación de toque metálico, deslizamos suavemente el instrumento, siguiendo tocando el instrumento metálico de la vaina del artroscopio, hasta la grasa posterior del tobillo, y ahí empezamos la limpieza, que requerirá unos minutos de limpieza. Colocamos al paciente con el tobillo por fuera de la mesa operatoria, en decúbito prono, con esta posición que veis aquí en las imágenes, que nos permite hacer flexoextensión de tobillo, y empezamos con el portal posterolateral. El portal posterolateral, buscamos el maleolo lateral, lo traspasamos este punto del maleolo lateral al borde lateral del tendón de Aquiles, y nuestro punto de entrada será 1 centímetro por encima de este punto. Y el abordaje posteromedial sería al mismo nivel, pero en el borde medial del Aquiles, al mismo nivel que el abordaje posterolateral. Son los dos abordajes que utilizamos en la artroscopía posterior. Aquí veis los dos, posterolateral y posteromedial. Cuando iniciamos la técnica, después de limpiar esta grasa posterior del tobillo, que requiere unos minutos, nos aparece el flexor hallucis longus, que es nuestro gran amigo, porque nunca hemos de ir medial en relación al flexor hallucis longus por el peligro que representa lesionar el paquete vasculonervioso. ¿Cuáles serían las indicaciones de la artroscopia posterior? Pues todo el cuadro de impingement posterior de tobillo asociado a la tendinitis del flexor hallucis longus, ¿no? Y aquí podemos hablar de los impingements óseos, que principalmente son el trigunum y el proceso talar posterior prominente o tubérculo de Stieda, y todos los impingements de partes blandas, como puede ser del ligamento intermaleolar, del ligamento tibiofibular profundo, un vientre muscular bajo del flexor hallucis longus, un dedo en resorte del flexor hallucis longus, la patología crónica de las bailarinas, de los corredores de largas distancias y de los futbolistas, y también las causas postraumáticas con tendinitis crónicas del flexor hallucis longus. Este sería un gran paquete, que es el de los impingements, y luego las otras indicaciones sería la artrodesis subastragalina, que en algún caso lo podemos asociar también a la tibioastragalina por vía posterior, la osteocondritis de astrágalo, luego veréis en qué indicaciones la osteocondritis de astrágalo, la transferencia del flexor hallucis longus, el Haglund y la aumentación del surco de los peraneos. Lo que os decía de la osteocondritis de astrágalo, en lesiones por detrás de la una es muy difícil llegar con abordajes anteriores, y es una excelente indicación hacer unas microfracturas, una técnica de microfracturas por vía posterior. En este, como un caso que os pongo aquí, otro ejemplo de otro paciente por detrás de la una, y que es mucho mejor ir por vía posterior que no por vía anterior. Aquí veis un ejemplo como por vía posterior realizamos la técnica clásica de microfracturas, limpieza del cartílago, desbridamiento del cartílago y la técnica de microfracturas por vía posterior. Aquí lo estáis viendo, ¿de acuerdo? Todo el grupo que os iba a explicar de la etiología del impingement posterior asociado con la tendinitis del flexor hallucis longus. Recordaros, ¿no?, que el proceso posterolateral es donde ocurre la fractura de Sheffard, el proceso posteromedial ocurre la fractura de Zedal, ¿no?, y en el posterolateral es donde podemos encontrar este megaproceso posterolateral que es el Stieda, o este hueso anómalo supernumerario que es el os trigunum, que también está en el proceso posterolateral. Hay que hacer un diagnóstico diferencial de cuál es la patología esta ósea que produce el impingement posterior. Si estamos hablando de un trigunum, os he puesto radiología, resonancia y TAC para que veáis las imágenes de trigunum, y aquí un megatubérculo posterior lateral de Stieda, que también os he puesto las imágenes en radiología y en resonancia para hacer el diagnóstico. Tener en cuenta estas estructuras posteriores. Veis el ligamento tibial, tibiofibular posterior superficial, el tibiofibular posterior profundo, el ligamento intermaleolar, y también veis cómo el posterior talofibular ligament del complejo lateral del tobillo y el calcáneo fibular, pero sobre todo el posterior talofibular ligament, se inserta en el tubérculo posterolateral del talus. y un poco más medial veis el groove, el surco del flexor hallucis longus, que es donde donde ocurre esta patología de compromiso entre el flexor y el hueso. Un ejemplo de resección artroscópica de un trígonum, vemos cómo estamos identificando el trígono, aquí vemos el ligamento tibio-fibular posterior profundo, el intermaleolar, la articulación tibio-astragalina por la parte posterior, empieza a mover ahora el trígonum, aquí el flexor hallucis longus, aquí lo veis, y empezaré a movilizar el trígonum para ver este hueso supernumerario que encontramos en la parte posterior del tubérculo posterolateral. Vemos el flexor, cómo lo estamos movilizando, y a partir de aquí veremos cómo logramos hacer la resección del trígono. Empezamos a movilizarlo, comprobamos que sea este hueso supernumerario, esta condrosis en la parte posterolateral del tubérculo posterolateral, empezamos a liberarlo, podéis utilizar lo que queráis, un vaporizador, unas tijeritas finas, un basket fino, el mismo proof del artroscopio que es duro y también nos permite la liberación, y finalmente yo utilizo una pinza de disco de columna para hacer la extracción del fragmento del trígonum. Un ejemplo también de un otro trígonum, aquí veis cómo vemos el flexor, cómo identificamos, cómo empezamos a liberar con el vaporizador, y aquí veréis cómo ya liberamos el fragmento y posteriormente lo extraemos con la pinza de disco. Aquí veis el proceso de extracción, ¿de acuerdo? El estieda. El estieda no es un hueso supernumerario, sino que es este mega proceso posterior de estieda, y con motor hemos de ir con mucho cuidado para empezar a hacer la resección que compromete este conflicto de espacio entre el hueso y el flexor hallucis longus. Un truco que puede ayudar es introducir un baselap para retirar el tendón del flexor hallucis longus, lo apartamos y de esta manera nos es más seguro y evitamos que el tendón se nos introduzca con el motor, con el sistema de la fresa motorizada, ¿vale? Una vez lo hemos apartado con el tendón, con el baselap es mucho más fácil proceder a la resección. Y insistiendo en esta patología del tubérculo posterior lateral y del groove del flexor hallucis longus, recordar que el flexor hallucis longus se origina en la parte posterior del peroné y en la membrana iterósea. A nivel de la articulación suprastragalina, el flexor discurre por este surco que comentábamos, que este surco está delimitado por el tubérculo medial y por el tubérculo lateral del talus, como decíamos. Aquí veis muy bien el tubérculo lateral, donde se insertará el ligamento peroneo astragalino posterior. Recordar que en el tubérculo lateral se inserta este ligamento, el groove y luego el tubérculo posteromedial más medial. Hicimos una investigación con 16 pies en nuestro servicio de anatomía de la Universidad de Barcelona y vimos que había un margen entre el surco, el tamaño, la anchura del surco y el tamaño del flexor hallucis longus, y aquí vemos el tamaño, la anchura total del tubérculo lateral. Esto nos llevó a decir que, teniendo en cuenta que en este tubérculo posterolateral se inserta el peroneo astragalino posterior, el ligamento peroneo astragalino posterior, es conveniente resecar hasta un máximo del 40% de este tubérculo. Resecando 40% de este tubérculo da suficiente margen para que el flexor discurra sin problemas y que no haya conflicto de espacio. Pero no lo resequéis todo, porque así no desinsertáis el ligamento peroneo astragalino posterior. Otros ejemplos de tendinitis del flexor hallucis longus sería un vientre muscular bajo. El vídeo está pensando, a ver si se nos abre y tenemos suerte. Lo veo un poco bloqueado, ¿no? Ay, no. Vale, paso del vídeo. Es una resección del vientre muscular bajo. Aquí veis otro ejemplo de un dedo en resorte, un ejemplo muy bonito de cómo se le bloqueaba al paciente. Era doloroso y lo que hicimos fue una liberación del tendón del flexor hallucis longus artroscópicamente con vaporizador y tijeritas. Aquí veis cómo localizamos el flexor, cómo había esta vaina con esta compresión que generaba la vaina del flexor hallucis longus sobre el flexor. Es un típico caso como el dedo en resorte de la mano, pero a nivel del flexor hallucis longus en el pie, y vemos cómo estamos resecando con cuidado, siendo cuidadosos, cómo vamos liberando la vaina del flexor hasta poder liberar esta compresión y este gatillo que reduce. Aquí veis cómo ya se abre muy bien la vaina y por lo tanto no habrá el efecto gatillo sobre el flexor hallucis longus. Un ejemplo muy bonito de una chica con un dolor crónico de años de evolución en el flexor hallucis longus, postraumático, tenía una compresión fibrótica alrededor del flexor. Hicimos un trabajo, lo mismo que os voy diciendo, ¿no?, de liberación de este flexor y de esta fibrosis. Este vaporizador en forma de gancho ayuda mucho para este tipo de liberación de la vaina vaina sobre el flexor, vamos liberando esta vaina hasta que llegamos a la parte más distal de la vaina. Aquí veis que aún queda un fragmentito, una vaina que aún puede molestar, la acabamos de abrir y de esta manera llegamos hasta la vaina más distal, cuando ya penetra en la parte casi plantar. Veréis como al final de todo se ve completamente liberado el flexor y sin ninguna causa de compromiso que pueda ocasionar dolor y compresión del tendón. El tratamiento del jáculum no os lo presento ahora porque mi siguiente presentación será el tratamiento de la tendinitis insercional posterior, lo dejamos. Otra buena indicación sería la transferencia del flexor al lecis longus, que también veréis que se puede hacer en la técnica de lesiones crónicas de la inserción del Aquiles, ¿no? Y aquí vemos cómo hacemos la transferencia del flexor al lecis longus, pero también os lo enseñaré luego cuando hablemos de la tendinitis insercional. Y ya para acabar, hablando de una técnica que también es muy útil, hacerla por vía posterior, que es la artrodesis de la articulación suprastragalina. Resecamos el cartílago de las dos superficies articulares. Al principio es un poco difícil de empezar a trabajar porque no tenemos espacio. Lo podemos hacer con un escoplo fino, con el shaver, con el bar del motor, ¿no? Poco a poco nos vamos generando espacio, cada vez es más cómoda la situación y vamos liberando hasta llegar a la parte anterior de la suprastragalina posterior. Llegamos a visualizar el seno del tarso, el ligamento interóseo del seno del tarso se llega a visualizar en algunas veces muy bien. Veis cómo vamos liberando, cómo resecamos todas las superficies cartilaginosas. Lo que más cuesta es la parte más posterolateral y posteromedial, que para esto nos ayudamos de una cucharilla, una curette nos ayuda mucho. Aquí veis los últimos fragmentos, en el fondo el ligamento interóseo de la articulación suprastragalina del seno del tarso. Aquí veis cómo estamos comiendo los restos de cartílago posterolaterales y posteromediales. Hay que lograr un buen contacto de toda la superficie ósea sin cartílago para lograr una buena coaptación y un buen contacto hueso esponjoso con hueso esponjoso, para finalizar la cirugía colocando 2 agujas de Kirchner, y a través de estas, aún estoy liberando, aquí veis cómo colocamos las agujas de Kirchner y a través de las agujas de Kirchner colocar 2 tornillos canulados que nos permiten la compresión de la articulación suprastragalina. Tenemos unos capítulos en estos 2 libros de Nick Van Dyke y de la Sociedad Americana de Artroscopia, que nos invitaron a hacer el capítulo de artrodesis suprastragalina, una publicación con nuestros resultados. Aquí veis algunos ejemplos con la técnica de artrodesis artroscópica, los 2 tornillos canulados, otros ejemplos de consolidación. Y ya para ir acabando, recordar que la técnica de artroscopía no está exenta de complicaciones a nivel del tobillo. Este es un estudio del grupo de Nick Van Dyke que presenta 1.300 artroscopias, y en estas 1.300 artroscopias habla de 46 complicaciones, un 3,5%, y de estas complicaciones 25 complicaciones neurológicas, 68 de las cuales persistentes. O sea, tener cuidado. Y quiero enseñaros este vídeo. Yo nunca voy a buscar el nervio, esto es el flexor al lecis longus, pero a veces sin buscarlo veis que el nervio está a 2 milímetros del flexor. O sea que tener cuidado porque el nervio está allí mismo y puede dejar una lesión permanente del nervio tibial posterior. Nos han llegado a nuestro servicio un paciente con una lesión completa del nervio tibial posterior, y un compañero también nuestro en Madrid también le ha llegado otro caso con una lesión completa del nervio tibial posterior, que cuando ocurre lo que hay que hacer es intentar mejorar la situación con un injerto fascicular, con nervio sural y con microcirugía para reparar la lesión y el gap de la lesión del tibial posterior. Bueno, ya para concluir, deciros que la resección artroscópica del tubérculo posterolateral no ha de superar el 35-40% de su amplitud, porque recordaros que allí se inserta el ligamento tibiofibular posterior. En el abordaje posteromedial, atención con el nervio tibial posterior, y en nuestras manos las principales indicaciones de la artroscopia posterior serían el grupo de impingements tendinitis del flexor al lecis longus, principalmente trigonomiestieda, la osteocondritis de astrágalo y la artrodesis de la articulación suprastragalina, y que también se puede asociar, si queréis, la articulación tibioastragalina. Recordaros que este año, como cada año, hacemos el curso en técnicas quirúrgicas en cadáver en la Universidad de Barcelona. Ya será el 15 año que hacemos el curso, y nada, simplemente deciros muchas gracias por vuestra atención.
Muchas gracias, doctor Javier Martín. A continuación, el doctor Kennedy nos va a hablar sobre la inestabilidad de tobillo, la perspectiva internacional.
All right, thanks again to Hugo, again, without which I wouldn't be here, and none of these slides we made. So thanks to our Peruvian international fellow. All right, I'm going to talk on ankle instability, an international perspective, and these are my disclosures, and this is what we're going to talk about. So introduction. The lateral ankle complex is the most commonly injured ligament complex in the body. In the United States alone, there's 27,000 ankle sprains every single day. And of those 27,000, perhaps 80% of them will recover. So we only have to worry about 20%, but that's a lot. And so when patients come to you, oftentimes it's difficult to examine them properly, and there's often a differential diagnosis. It could be an osteochondral lesion, it could be a syndesmotic lesion, it could be a Jones fracture. It's difficult to evaluate. And if you're worried about it, you can always give a small injection, local injection, to truly see whether they're unstable. I think radiographs are useful. They can certainly see if there's an opening. Again, if you can examine them, you can put them on a TLOS machine to see if there's any instability. But I think the gold standard for us when patients have ankle instability and we want to determine what the ligament looks like, and we want to determine what the other lesions are that are associated with lateral ankle instability, we get an MRI. So as I alluded to, up to 70% or 80% of these will heal, but those that don't is what we're going to talk about today in terms of how do we operate on these. So there's basically two types of procedures. There's an anatomic or check rein procedure, and then now we're doing more and more arthroscopic procedures. So we'll talk about the open procedures, anatomic, first of all, Brostrom, Carlson, Gould, and the hybrid, and then we'll talk about autograft versus allograft, and then we'll talk about check rein, which are mostly historic, I believe. So back in the 1960s, a Swedish surgeon, Brostrom, described this technique, and up to that time, most people were doing check rein procedures. They're using tendons to augment for ligament. But Brostrom was the first to describe this, where he actually was able to suture the two ends of the torn ligaments, and using that technique, he had excellent outcomes. This was his original study, 97% success. That's amazing. You get 97% success in anything, that's a good surgery. So it really has stood the test of time. But perhaps what we're doing mostly, rather than the original Brostrom, I think most of us are doing what John Carlson has modified. John is a dear friend, and this is what he described, which is reattaching the ligament to the fibula, because most of us do that. When you open up a ligament that's been torn for a long period of time, it's mostly scar tissue. It's hard to find the two ends as Brostrom did, so most of us now attach it onto the fibula itself. Now Gould modified this by bringing in the inferior extensor retinaculum, these frondiform superior lateral bands of the inferior extensor retinaculum then are pulled up to augment the original repair. And the short-term results of that were excellent. Patients were doing good, but anything that's worthwhile must have good long-term evidence. And when you look at the long-term evidence in this, again, over 10 years, mostly 80 to 90% success, and less than 1% or just around 1% revision rates at almost 10 years. So that's a very good surgery. Hard to improve on that. This is our technique. We make a small incision. It's less than 4 centimeters. We find the anatomic footprint of the ATFL, both on the fibula and the talus, and typically it's on the fibula that we make our scoring for these small little suture anchors that go there. We attach the ATFL into that, and then we oversew the inferior extensor retinaculum and surrounding capsule. By doing that, we don't usually have to look at the CFL. It's very rare that we do a primary repair of the CFL any longer. By tightening the floor of the perineal sheath, and we should always look at the perineal tendons, by tightening the floor of that, you actually tighten up the capsule around the subtalar joint and the CFL also. So all of that looked good till everything looks good till you start to actually review it. And so we did this. We looked at the inferior extensor retinaculum, and again, a nice study done by John Carlson and Gino Kirchhoffs. And we looked to see whether it really made a difference in the mechanical stability or patient outcomes if the rostrum Gould or modification is done well. And really, the anterior inferior ligament extensor retinaculum is not necessary. And it may, in those patients or in those patients who have a low-lying superficial perineal nerve, it may cause iatrogenic nerve injury. Still do it, but it's just something you don't have to do it to get good outcomes. So then we talked about a hybrid procedure. In those patients who have a collagen deficiency, or when you go in and you find the ATFL is like tissue paper and you can't get a suture into it, then we look at other types of autograft or allograft. The hybrid is an autograft. And for years, people have been using the Peroneus brevis, the primary dynamic stabilizer. It didn't seem to make sense. So we used the Peroneus longus because that's primarily a plantar flexor of the first ray. So when we use a small slip of Peroneus longus and we augment the original ATFL with a 4 centimeter graft in there, patients do well. This is how we do it. Again, it's a 4 centimeter incision. We identify the ATFL, the anatomic footprint on the talus and the fibula. We take our graft, we oversew the Peroneus longus, and we put in drill holes for an interference screw. And then we put in our graft under moderate tension in there. Patients do well. This was our first study of this. Dr. Chris Morosky was again one of our fellows, a really smart guy working in UPMC in Pittsburgh now, and he looked at 57 patients that we did this on, and again, the likelihood of success was very high. One thing we did find was that functional stability was the area that patients did not have anticipated great results. So we now concentrate a lot on physical therapy after this. But again, hybrid operation is very useful. So should we be using an autograft? Is that going to cause any problems to the longus? Can we take a semitendinosus? Can we take a plantaris? Or should we be taking allograft? And again, a nice study by Stéphane Guillot, who's part of this International Ankle Instability Group, has shown that really, if you can, an autograft is a better graft to take because there's an MHC mismatch, or can be, in allograft. It can stretch or creep out over time, and it can create inflammatory responses if you use an allograft. It's readily available, but it's expensive. So I think an autograft, if you have ATFL incompetence, an autograft is the best way to go. You can take semitendinosus if you're used to, but the Peroneus longus is looking at you, it's right there, and it's easy to do with excellent outcomes. Now we'll talk about check rein procedures just simply because it's anatomic. The Evans procedure, the Watson-Jones procedure was described in the 1950s, and then the Chrisman-Snook, which we all learned back in residency, again, I think is more of an anachronism now. We don't really do these any longer, but they're there for completeness. And this was, again, a nice study from the Carlson group and the Nick Van Dyke group looking at an international study on this, and they looked at those that were treated with tenodesis and those that were not, or just treated with an anatomic repair, and the tenodesis study did poorly by comparison. And I think you can over-tighten the tenodesis group and create problems in the subtalar joint. So this is all about arthroscopy, and so if you look, arthroscopy is terrific because if we look at a simple ankle sprain, there probably is no such thing as a simple ankle sprain. And Christy Giovanni has written a paper on this and showed that 70 to 90% of patients with a significant ankle sprain will have concomitant pathology, whether it's a perineal tendon tear, whether it's synovitis, a loose body, an osteochondral lesion. So it's incumbent upon us, if we're operating on an ATFL, to look for these things, and the best way to look for them is with a scope, and that's what we've been doing for many years. So this was the first, it was Dr. Acevedo and Dr. Peter Mangone had this procedure known as the arthrobrostrem. The arthrobrostrem was the first attempt really at an ATFL reconstruction. But it really wasn't. It was putting in sutures arthroscopically that were tightening all the soft tissues around there, but there was a high risk of nerve injury because the superficial perineal nerve, or indeed the sural nerve, can be lying in a position that's not in the anatomy books. And in those cases, unfortunately, the nerve was injured. So the results of that were good functionally, but too many complications. Second generation arthroscopic procedures were popularized by Mark Glazebrook, Masato Takao, and Jim Stone. Jim sends his regards. He's the president of ANA this year, and he sends his regards to this esteemed society and wants to have a greater collaboration moving forward. But Jim came out with this nice, where he used a 3-portal technique using a graft to do an arthroscopic reconstruction of the ATFL and CFL. Because there was 3 portals involved and because it was a little bit complicated, we tried to modify it, so we came up with a 2-portal technique, and it was slightly easier. One of the great mentors of the British Orthopaedic Association used to say, it must be remembered that the average orthopedic surgeon is an average orthopedic surgeon, and so we got to keep things simple. And so that's what we've done. We kept it with this 2-portal technique. We're able to do an arthroscopic ATFL very simply. We now use an internal brace. An internal brace is just, it's like an augmentation device. We put it into into the anatomic footprint of the ATFL on the fibula and the talus. The key to this is not to over-tighten it, because if you over-tighten it, it really will cause problems with the posterior facet of the subtalar joint. And we can do this arthroscopically, and then we leave the ATFL because they're proprioceptive fibers, and even in that remnant of the ATFL, which we don't want to disrupt. Now recently, as I alluded to in my earlier talk, we talked about in-office nanoarthroscopy, or in-office needle arthroscopy. So we can do this 2-portal technique in the operating room, and they thought, well, why can't we do it in the office? Because now with FIFA and other big sporting organizations saying that it's probably best to operate early on ATFL injuries in professional sports people, the time to return to play is predicated upon the incision side and how quickly we can mobilize them. So we thought, why don't we do this in the office? And we've done that. And we published our technique paper in arthroscopy recently. So we can do this, the patient is awake, and it takes around 30, 40 minutes, and the patient gets off the table and walks away. So their return to play times are within a month versus 6 weeks for standard arthroscopy or 3 months for our open procedures. This is how we do it. Again, we find the ATFL. We take some of that Bassus ligament that we talked about earlier. We take that away so we can see the ATFL footprint, and then you can see here we're putting in our suture anchors into the fibula and into the talus. So again, this is why we're doing it. This is a really nice study from the Fortius Clinic by James Calder and Graham McCollum, and it really shows that return to sports at approximately 10 weeks, safe and effective treatment, because in a professional athlete, weeks are very important. So if it's me, it doesn't matter if it takes 3 months, but as a professional athlete, it really does. So that if you can get that athlete back playing within a shorter period of time, that's critical. And so that's why they opt to operate early rather than wait for a traditional conservative therapy, which may fail or 20-30% chance of failing, so they go straight to surgery. So the modified rostrum is a very useful procedure, and that's what we're doing here with these check rein procedures. It's a modified rostrum. So you talk about suture tape. Well, we talked about suture tape. I was not a big fan of suture tape. There was a device that we used to use, a ligament augmentation device many years ago for ACLs, and the problem was it created cyclops lesions because of micro wear particles in the knee. So I was concerned about this, using suture tape within an ankle. Are we creating small fibers in there that would create cicatrization and scar? We did multiple tests on that, and then we did a systematic review. This is a nice study done by Nate Mercer, who's one of our residents at NYU, and he showed really that the likelihood of any complication from suture tape is minimal, and that the long-term results are equivalent to whether we do an open procedure or we do an ATFL. And in fact, the return to play is far quicker in the suture tape group. This again is a nice study, just again showing arthroscopic versus open repair. Arthroscopic now has less complications than open repair. Return to play time, I know we're at a crunch here in terms of time. So return to play, we go through a triple phase rehab in NYU. The most important thing, as I said earlier on, is it's critical for functional stability. Mike Freeman back in the 60s described functional stability. It's a proprioception, and it's the ability to know where your foot is in space. As surgeons, we can address mechanical stability. Physiotherapists and patients have to address functional stability, and it's up to us to inform them how to do that. And that's the key. So every one of our patients that we mechanically stabilize, it has to be that we see them through to functional stability. So So I think in summary, ankle arthroscopic procedure is less invasive for an ATFL reconstruction, allowing for functional improvements in all athletes. I think we have to know anatomy. You have to mark that out very carefully beforehand so we don't prang that. Important patient selection. Patients need to be aware that afterwards they're not hanging around. We get them moving very quickly into a rehab program. And I think biological augmentation will be useful. We talked about that in the previous study. It is useful also in ATFL reconstruction, but it's a whole different talk. But I think that's the way we should move forward. And I think many of these will be done in office moving forward. It's going to be like going to your dentist rather than your orthopedic surgeon. We can do these quickly, and we can do them efficiently with a high degree of likelihood of return to play in a short period of time. Thank you very much.
El doctor Martín nos disertará la charla tendinopatía insercional del Aquiles.
Bueno, después de hablar de la artroscopia anterior de tobillo, la artroscopia posterior, las lesiones ligamentosas por inestabilidad lateral, ahora voy a pasar a otro tema que es la tendinitis insercional del Aquiles. Es una patología bastante frecuente, representa el 25% de las lesiones que afectan al tendón de Aquiles. ¿Cuáles serían los factores predisponentes de esta tendinitis insercional? La edad y la obesidad son factores que influyen. Una alteración mecánica con el varo del retropié también puede influir en la aparición de estas tendinitis. También hay antecedentes genéticos y familiares, ¿no? El riesgo se aumenta cuando hay un antecedente familiar por 5, ¿no?, de aparición de estas lesiones. Los corticoides también afectan la maduración y la resistencia del tendón, y también la práctica deportiva. Este trabajo excelente del grupo de Asplund habla de un 29% de aparición en deportistas frente a un 4% de aparición de la tendinitis insercional del Aquiles en no deportistas, ¿no? ¿Cuál es la clínica de la tendinopatía insercional? Bueno, pues suelen ser pacientes jóvenes, atletas, algunos que hacen deporte, o pacientes mayores sedentarios, y tienen un inicio insidioso de dolor en la parte posterior del talón. Se puede asociar con enfermedades reumáticas seronegativas, siempre buscar y estudiar esta posible patología y esta posible causa. Y aparece un dolor en la cara posterior del talón, un dolor que puede ser al levantarse por la mañana o también tras estar un rato de reposo. Mejora si colocamos un calzado con algo de alza en el talón. Se ve un engrosamiento posterior en la parte posterior del talón, un dolor que aumenta la flexión dorsal, siempre valorar si el paciente presenta pie plano o pie cabo, y también siempre una evaluación del gastrocnemio con el test de Silverhorn es importante realizar en estos pacientes. La radiología es fundamental, la radiología lateral en carga, evaluando el ángulo de Fowler-Phillips, que ha de ser menor de 70 grados, también el ángulo de pitch, que ha de ser menor de 20, y el total angle en esta zona posterior del retropié sería la suma del Fowler más el pitch. Especialmente esto te demuestra cuando hay un Haglund, aumenta este ángulo de Fowler y puedes hacer el diagnóstico de confirmación. La resonancia también es importante realizar en estos pacientes con una tendinitis insercional. Hemos de descartar lesiones intratendinosas, hemos de ver aumentos intensos de señal en la bolsa retrocalcánea, especialmente en la proyección T2 de la resonancia, y también hemos de descartar cambios degenerativos o inflamatorios en la inserción tendinosa del Aquiles. En nuestra práctica vemos dos formas de presentación de esta tendinitis insercional: el Haglund típico más la bursitis retrocalcánea asociada siempre, o también un Haglund pero asociado a un espolón posterior, que aquí veis algunas imágenes, y con calcificaciones posteriores intratendinosas del Aquiles. En ambas presentaciones el Haglund está presente, por lo tanto un homenaje al que lo describió en el año 1928, profesor del Karolinska Institut en Estocolmo, Patrick Haglund, que describió este aumento de la tuberosidad posterior del calcáneo que creaba este conflicto de espacio entre la parte posterior del calzado y el calcáneo. Suelen ser pacientes jóvenes, se aprecia este aumento de la tuberosidad posterior del calcáneo, es más frecuente en mujeres, esto agravado por el calzado, y también se suele asociar un un eritema, una inflamación local y una irritación de la piel y, por supuesto, dolor, un conflicto de dolor. El ángulo de Fowler-Phillips, como os decía, en la enfermedad de Haglund siempre está aumentado por encima de los 70 grados y tendríamos que hacer un diagnóstico antes de realizar el tratamiento del conflicto insercional del Aquiles. Si estamos simplemente al Haglund con la bursitis o el Haglund con el espolón y calcificaciones posteriores. Es muy importante esta diferenciación entre uno y otro. Ambos cuadros clínicos tienen un tratamiento conservador parecido, suele ser prolongado, no tengáis prisa en operar estos pacientes, un tratamiento prolongado entre 6 y 12 meses, con reposo, calzado adecuado, antiinflamatorios, plantilla, un alza en la parte posterior del talón, crioterapia suele ayudar, rehabilitación funcional y también es muy importante realizar ejercicios excéntricos y estiramientos. Aquí veis un ejemplo de estiramientos, cómo hacemos los estiramientos y cómo recomendamos al paciente que haga estiramientos para tratar y mejorar esta patología de la inserción del Aquiles. O también ejercicios excéntricos. Los excéntricos tienen mejor respuesta cuando no es una patología insercional, requiere compromiso por parte del paciente y constancia. ¿Y cómo actúan estos excéntricos? Actúan comprimiendo la vascularización del peritendón, por eso actúan mejor en las patologías no insercionales. Esto crea una falta de aporte de oxígeno y secundariamente se lesionan los nervios que inervan el paratendón y disminuye el dolor. La imagen de cómo recomendamos hacer estos excéntricos la veis en este vídeo. Suelen ir bastante bien. En cuanto a infiltraciones, puede ser ácido hialurónico, sustancias esclerosantes, corticoides, PRP, bueno, en una encuesta que se realizó en esta publicación de Johnson, el Foot and Ankle International, el 88% de los encuestados no emplean corticoides en la tendinitis insercional. Nosotros no lo utilizamos nunca y también es interesante ese trabajo del grupo de Bell que no evidencia clínica de mejoría y de eficacia con los PRPs tratando este tipo de patologías insercionales. Las ondas de choque sería otra alternativa de tratamiento conservador. Encontramos publicaciones que hablan de 60 o 80% de buenos resultados utilizando las ondas de choque en este tipo de patologías insercionales. Y ya pasando al tratamiento quirúrgico, lo hacemos diferente según sea un Haglund o bursitis o un Haglund más o espolón posterior. Si no hay calcificaciones posteriores ni exóstosis posteriores, tenemos dos posibles indicaciones para tratar a estos pacientes: la clásica calcaneoplastia abierta o artroscópica, más bursectomía, o la osteotomía de Zadek. Si existen calcificaciones o exóstosis posteriores, hacemos una incisión longitudinal del Aquiles, bursectomía, calcanoplastia y resección de calcificaciones y exóstosis. Ahora lo veréis. En el primer supuesto, cuando no hay calcificaciones, lo que hacemos es una resección clásica de la tuberosidad posterolateral con una incisión lateral. La tuberosidad superior del calcáneo presenta una técnica que suele dar buenos resultados y también se puede hacer por técnica artroscópica. Antes os lo decía cuando hablábamos de los abordajes posteriores, con unos abordajes posteriores que os he descrito antes, quizás ligeramente un poco más inferiores, medio centímetro los dos portales más inferiores, podemos hacer la resección de la bursa y la resección de la tuberosidad posterior del calcáneo, como estáis viendo en este vídeo que os estoy enseñando. Es una técnica no demasiado difícil, entretenida, divertida de hacer, pero quizás entretenida. Esto sí, a veces tardas menos haciéndolo con una pequeña incisión lateral que no haciendo todo este procedimiento artroscópico para resecar esta tuberosidad posterior del calcáneo, ¿no? O sea que a veces, en algunos casos, no sé si compensa hacerlo vía artroscópica porque el riesgo de la incisión lateral es mínimo, no hay complicaciones y la resección en 10 minutos has hecho la resección de la tuberosidad posterior. Algunos ejemplos radiológicos: pre y posoperatorio con la resección de la tuberosidad posterior del Haglund. Aquí veis pre y posoperatorio. Y la otra opción que nosotros especialmente lo utilizamos en casos de recidivas es la osteotomía de Zadek. La ventaja de la osteotomía de Zadek es que disminuye el ángulo de pitch en estos pacientes con un cabo posterior, necesita una osteosíntesis después de realizar la osteotomía, precisa descarga, ocasiona un ligero ensanchamiento del talón. Realizar esta bisagra no siempre es fácil y tiene una cierta afectación sobre el brazo de palanca del sistema aquileo calcáneo plantar. Nosotros utilizamos casi siempre la resección que os he enseñado antes de la tuberosidad posterior por vía lateral o artroscópica. Reservamos la osteotomía de Zadek para los casos de recidiva de la patología esta de la tuberosidad posterior. El segundo grupo es los pacientes que tienen la tendinitis insercional con el espolón y calcificación intratendinosa, y pueden haber también lesiones parciales del Aquiles en estos pacientes. Aquí veis otro ejemplo típico de esta calcificación bastante grande posterior. ¿Qué hacemos en este tipo de pacientes? Hacemos una incisión posterior longitudinal sobre el tendón de Aquiles, llegamos a la inserción del mismo y lo desinsertamos parcialmente, sin llegarlo a desinsertar totalmente. En L, hacemos 2 L sobre el tendón de Aquiles, siendo cuidadosos, para que esto nos permitirá hacer la resección del haglund por vía posterior, resecar también las calcificaciones intratendinosas si existen y, por supuesto, resecar la exóstosis o espolón posterior. Hay que ser cuidadoso con la técnica para no desinsertarlo totalmente, el Aquiles, es un detalle importante, y cuando ya tenemos preparado el campo operatorio, con una sierra hacemos la resección del haglund, hemos ya resecado, si es necesario, las exóstosis posteriores en la inserción del Aquiles y también las calcificaciones que puedan haber intratendinosas. Es una cirugía muy bonita de hacer. El único detalle importante es no llegar a desinsertar de todo el tendón de Aquiles, que si pasa, nosotros siempre, aunque no lo desinsertamos del todo, colocamos 2 anclas, pero si se inserta del todo, pues has de ser mucho más estricto con la colocación de las anclas y asegurarte. Pero nosotros, aunque no lo desinsertamos del todo, siempre colocamos 2 anclas de seguridad, por si acaso, para no quedarnos nunca sin Aquiles. Y finalizamos la cirugía cerrando la incisión longitudinal del Aquiles. Los conceptos básicos es abrir o desinsertar la inserción para secar la calcificación y el haglund, procurar nunca desinsertarla completamente, y si se desinserta, pues hay que reinsertarla con Statax, que nosotros también ponemos, aunque sea parcial, y como alternativa tendríamos hacer una plastia de transferencia con el plantaris o con el flexoralis longus. Ahora os enseñaré, cuando pasa este caso, cómo se puede hacer una plastia de transferencia. Aquí veis la resección de la espolón posterior y la reinserción con los 2 Statax. Siempre en este tipo de pacientes con tendinitis insercional del Aquiles, explorar si existe una posible contractura del gastrocnemio, porque estaría indicado asociar a la técnica un alargamiento del gastrocnemio medial, y en pacientes en los cuales se produce una desinserción, y especialmente en los pacientes ya crónicos que existe una desinserción con gap tendinoso, si la desinserción es menor de 5 centímetros hay que hacer un alargamiento VY y reinserción con arpón. Si el gap es mayor de 5 centímetros ya tenemos que pasar a hacer una transferencia con el flexoralis longus, o como última técnica de rescate en graves desastres, la técnica con banco de hueso bone tendon graft para suplir. La técnica de traslación VY es muy útil cuando el gap es menor de 5 centímetros. Aquí veis un ejemplo cómo hacemos la técnica VY de traslación y cómo suplimos el gap tendinoso. Aquí veis, en un caso en el que había un gap más importante de 5 centímetros, aquí hicimos una transferencia del flexoralis longus, en este caso lo hicimos abierto. Aquí veis cómo estamos reinsertando el flexoralis longus en el calcáneo, y esta misma técnica se puede hacer también por cirugía artroscópica, como os he enseñado antes. Aquí veis la técnica finalizada con el trasplante del flexoralis longus sustituyendo el gap del Aquiles, pero también, como os he enseñado antes, podemos hacer la transferencia del flexoralis longus, cómo cortamos el flexoralis longus, cómo preparamos un túnel en la parte posterior del calcáneo, de la tuberosidad posterior del calcáneo, y una vez hecho el túnel lo que hacemos es pasar los hilos con unas agujas pasadoras que sacamos por la parte inferior del calcáneo. Aquí veis cómo estamos haciendo la técnica, el túnel, y veréis cómo pasaremos una aguja con los hilos y cómo pasaremos el tendón. En casos de grave desastre, como este que veías, es un caso de una secuela de una infección grave, que había desaparecido toda la parte distal del tendón de Aquiles, lo que hicimos también fue la transferencia del flexoralis longus abierto, haciendo una resección de la necrosis de todo el tejido necrosado y realizando la transferencia, que realmente funcionó bastante bien y suele suplir bastante bien la falta del tendón de Aquiles. Este es el caso que os he enseñado de la grave necrosis. Para concluir, el uso de alza mejora la sintomatología de la tendinitis insercional. El tratamiento con ejercicios excéntricos, crioterapia y ondas de choque ha de ser la primera fase de tratamiento de estos pacientes durante 3-6 meses. La calcaneoplastia asociada a bursectomía es la técnica más frecuente y que da buenos resultados. Es la resección de la tumoración de haglund, ¿no? Si presenta al paciente espolón o calcificaciones posteriores, el abordaje transaquíleo quilio es una buena opción y no existe evidencia de la efectividad del tratamiento con PRPs porque no mejora el dolor o la función en comparación con otros tratamientos. Os recuerdo otra vez el curso de noviembre que viene en la Facultad de Medicina, y Barcelona es la capital de Cataluña, no es tan grande como Lima, pero es una ciudad preciosa que seguro que podéis disfrutar, y muchos de vosotros habéis estado, y cualquiera que quiera estar como fellow entre nosotros puede venir a visitarnos en esta pequeña ciudad de la costa mediterránea. Gracias por vuestra atención.
Muchas gracias, doctor Javier. A continuación, el doctor Kennedy con el tema de conceptos en nanoscopía artroscópica.
All right, so this is my last talk for today, and we're going to talk about nanoscope and our foot and ankle experience. And these are our disclosures, and this is what we're going to talk about. So this is what a nanoscope is. For the last 30 years, we've been using the same instrumentation. It's a big black box, which doesn't really fit in your hand very well, and it's a big tube, and it doesn't really fit into small spaces very well. So a nanoscope has got chip-on-tip technology. It's less than 2 millimeters in diameter, and it's ergonomically designed. You can really handle it far better. We're always worried about small scopes that the quality of the image would be poor, but we're using chip-on-tip technology rather than refractory lenses now, and you can see that the quality of a 2 millimeter scope is every bit as good as our standard arthroscopy equipment. So really what we're doing, and it's important to emphasize, with in-office nano arthroscopy, the procedure is exactly the same as what we're doing in the operating room. It's with a smaller scope, smaller instruments, and so therefore less damage to soft tissues and increased recovery times, or faster recovery times. We just use a standard room in our clinic for this, and this is what we typically have. You have the scope, it's a throwaway scope, and you have these throwaway instruments as well, all very specifically designed for nano. One of our biggest concerns is when you have a biter, and it's only a 2 millimeter biter, what's the strength of this? So this is after we did one or two of these, we're just cutting the cord, and you can see the biter here is incredibly strong. It's not going to break. And even if it does now, we have a small little metallic device or a magnet device which will remove it. For many years, nanoarthroscopy was just the ability to see. We could see inside a joint in an office. Now we have the ability to do, and we have the ability to do because we have all of these bone prep tools that we have. These are all, again, 2 to 3 millimeters in diameter. We now have smaller shavers and burrs. So everything we use in the operating room has been miniaturized so that we can now do this in the office. So these are the benefits. Again, this is a 1.9 or 2 millimeter scope. It provides new options for MRI. MRI is not ubiquitously perfect when we look at lesions, either chondral lesions or we look at tendon lesions, particularly around the lateral side of the ankle. So we want to have the ability to see, and as I said, now we have the ability to do. So it's not going to remove MRIs, and it's not going to remove a main operating room, it's going to improve upon those. And part of the reason is not only do we have new technology, but we have greater patient demand. Where I come from now, in Manhattan in New York, patients want to have things addressed, but they don't want to have long recovery times. They don't want to pay for big operating costs into an operating room. So if we can do things, simple things, simply in an office, it behoves a great future ahead for us. So we've looked at this, but again, we're doing this in collaboration with AMC. Gino Kirchhoff's in AMC is my collaborator there. He was working with Nick Van Dyke for many years. And so we're looking to see where is the lane that this best operates in. So we talked a little bit about this before, about iatrogenic injury. This is a really nice paper by Jorge Vega, which shows that overall 31% of the time that you put a scope in an ankle joint, it's going to end up with iatrogenic injury. And that means that that cartilage doesn't repair. So if you have a smaller scope, the likelihood of that injury is reduced. And again, it goes back to this, that if you damage that, it's not going to repair itself. So these are some of the things that we can use a nanoscope for. It's in the ankle, knee, shoulder, hand, and wrist. And this is a patient, this is our setup. We do it like it's an operating room. We use all the same sterile equipment, You don't have to, but I think for the first 1,000 of these, we're going to do that for fear of infection. But the things that we can do in an ankle joint, we look in osteochondral lesions, we can now treat those. For impingement, we talked about anterior impingement and posterior impingement. Subtle syndesmotic instability, we can identify and address. Ankle fracture reduction, we can do that. And chronic ankle pain of unknown etiology. So we can treat loose bodies, synovitis, osteophytes, impingement, osteochondral lesions, and we can even do ATFL repairs. How do we do it? Same way as we would do a standard scope. We use exactly the same portals, they're just smaller. We infiltrate with lidocaine and marcaine into the joint and into the surrounding structures. And when you do that, patients don't have any pain. They're watching it as you are watching it. This is what we do. The things that we've done so far is we've done ankle scope, posterior scope, subtalar scope, perineal tendoscopy, posterior tibial tendoscopy, Achilles tendoscopy, tailor-navicular joint, first MP joints, and we can even scope lesser MTP joints. This is the setup. This is our first results or outcomes. Again, we can do everything. It's only when you look at your outcomes you recognize whether they're any good at it or not. This is Chris Colasanti's work. He was one of our researchers, and Hugo helped him a lot setting this whole study up. And we looked at our first 31 patients who had anteromedial impingement, and you can see that the return to play time is under a month. That is important for professional athletes and for all of us, really. And so patient satisfaction was 96%. Return to work, under 2 days. So you don't have these long recovery times that you do if you bring this patient to the operating room, and you reduce costs exponentially. And again, the important thing is when we mined into this information, 94% of the patients said they would have the procedure again. But the most important thing about the patient's response to this was they felt engaged. They felt by them looking at the camera, looking at the screen and seeing what was going on in their ankle joint and the knee joint in some cases, that they really could understand what was going on, and their expectations of post-op recovery were suitably tempered because of that. These are first nano cases. Now, we got this nano about 2.5 years ago, and it was delivered to my office. I didn't know what to do with it, so I'm a middle-aged ex-rugby player with a lot of knee injuries, so I thought the best thing to do is to look at my own knee, so I did. And this is my knee. It doesn't look pretty. So I will be using PRP. Unlike my colleague, I do believe in biologics, and I think for a knee like that, PRP is a useful thing, as is HA, and I've been injecting it because of this looks pretty grim. So ultimately, I'll probably need a knee replacement, but it was a good indicator. I had no knee pain. I can run. I can do all the sports I want, but put a camera in there, and I really do see what's going on here. It's not good. So this is anterior impingement. This is a really cool case. This is a guy, 61-year-old male. He had 2 ankle replacements, still complaining of pain. So he had anterior ankle pain and posterior pain, and he had gutter pain. So we put the camera in, and you can see the ankle replacement is pretty good. This was all this cicatrized or scar tissue around there. He had some bony overhang, and we're able to do this. Now, obviously, we kept him on antibiotics for a few days afterwards, but we can do this in the office, and he was so happy with this. Ultimately, he did require a poly replacement, but that was for more of a mechanical issue than a biologic one. This is a 26-year-old female who failed conservative management. She had anterior ankle pain, unable to participate in sport activities. And this is, again, we talked about anterolateral impingement. This is a hypertrophic Bassett's ligament, and you can see that we're resecting it here. This is in the office. The patient is looking at this and is aware of what we're doing. We also went over the medial gutter, and we resected on the medial side, and here you can see she had a small tibial osteophyte with an overhang and soft tissue resection. And this is with a 2.5 millimeter resector, I think. So it just takes a little bit longer because the instrument is smaller, but you can see the visualization here is perfect. It's every bit as good as if we brought this patient to an operating room. This is a guy who had a microfracture done in another facility, then he had an Oates fracture done, or he had an Oates replacement done by us, but he continued to have cicatrization or arthrofibrosis, a lot of scar tissue in his ankle joint. You can see the Oates graft was incorporated well, but again, he has this massive amount of scar tissue. So when we went in here, you can see this complete integration of the graft. He had a massive amount of scar tissue. And if you just mechanically debride that, it'll bleed. And the likelihood is it'll recur again. So this is one of the first times that we use these little ablator. And again, you wonder, is the patient going to feel the heat? Are they going to feel the pain just under local anesthetic? No, they don't. This patient is asleep, watching everything that's going on, and did well afterwards. We heard a very nice presentation by Dr. Martin on posterior arthroscopy, and I think we're moving forward now. We can do posterior arthroscopy in the office. 23-year-old female. She had an os resection done St. Elsewhere's. Didn't work. She had recurrent ankle pain, and she had recurrent ankle pain because of this massive amount of scarring back there. This is the setup. She is on her computer, lying down there, and we're able to go in and we're able to resect all of this scar tissue. And you can see all this scar tissue around her FHL, so she had FHL tenosynovitis, and we're able to resect this, again with a small resector. Patient is awake, there's the FHL, and you can see it's just all scarred in. So we're able to liberate that very nicely with a nanoscope and the instruments that we have. This is a 53-year-old male, long-standing history of right ankle pain. Again, he has FHL tenosynovitis and an os. So we go in, and you can see he has a loose body, which we didn't see on MRI. We're able to remove that. We also have small burrs. There's a 3-millimeter burr that we're able to put in there. There's his FHL. And you can see the tenosynovitis, and we're able to take away. Now, unlike when you do it in a larger scope where you can actually take out an os, pretty big os through a 4-millimeter incision, the incisions here are small. They're only 2 millimeters. So you actually have to burr this away and then suck it out. So that's the only difference, really. This is an interesting case. This guy is, he's not going to be playing in the US Open, but he's in the Junior Open in New York this year. He's a 17-year-old tennis player. He had posterior ankle impingement due to a steatal lesion. Failed shockwave therapy and failed all other modalities. So we brought him to our room, and you can see he had a large FHL tenosynovitis and a steatal lesion. And then a couple of days later, he's back out playing. So again, return to sports within a matter of days rather than weeks and weeks that we have in traditional procedures. This is a talus OCL, 40-year-old male. He had an Oates procedure, pain in the anterolateral or anteromedial aspect of his joint, and we're able to go in. You can see that this is we didn't even need an AMI view on this. We can see that he has impingement. And again, we can go in here. This is all the scar tissue, the front of his joint. And we can resect that again with a small resector. Patient is awake and seeing what's going on. And therefore, as soon as it's done, get off the table. There's nothing to regenerate and repair here. We're just taking stuff away, and they get off the table, and they get into immediate rehab in this. This again, the triathlete that we talked about. This is when we went in second look after biocartilage. You can see sometimes on MRI the biocartilage looks good, but we can see this is terrible cartilage, so we had to go in and replace that. There's another guy, subtalar joint and perineal tendon. This is an FBI agent who came in and he couldn't run, and he was going to get thrown out of the service because he couldn't run. He'd been to several doctors. He had lateral ligament reconstruction. Nothing was working. So we had a look at this. This is him. That's the FBI agent watching everything that's going on, and we're looking into his perineal sheath, and you can see that he has a stenosis of the perineal sheath and snapping subluxation, and we're seeing that there, and we can address that fairly easily. Getting rid of all this scar tissue that's in the sheath, and he's back out now catching bad people. This is an interesting case. There's a 22-year-old or 23-year-old female. She had a Salter-Harris 2 lesion when she was small, Salter-Harris 2 fracture. Since that time, she really had pain every time she was performing. Posterior medial aspect. She had multiple referrals. She came to us. We did an ultrasound, and you can see on ultrasound she had this Salter-Harris lesion, but that zone of Ranvier that we all know about, the cambial layer of periosteum, had overgrown. So she had this small little bony overgrowth right there when compared to the normal side. Wasn't picked up on MRI. And so we brought her to our nano suite, and this is the posterior tibial tendon here, and we've just resected that piece of bone, again using a small resector. Patient is awake and aware of what's going on, and she did really well. This is a 34-year-old Achilles tendon, non-insertion tendinopathy, failed shockwave. Everything we do has to be evidence-based. So for shockwave, about 70% of patients do well with non-insertional tendinopathy. PRP, around 50 to 60% of patients. I think it's important to note that not everything works with PRP, not everything works with shockwave, but we should always try those things first. This is what we do. We got into the Achilles tendon. We're able to get into the paratenon layer, debride that completely, and then find the plantaris, which is often out of phase in these Achilles tendinosis, and we resect the plantaris all while the patient is awake. This was actually a colleague of mine. He was an endocrinologist, and he got up and was so happy that he was able to run right after this. This is an interesting case. This is a patient who had a polyvinyl insert into her first MTP joint. These were popular in the United States about 5 or 6 years ago, and they subsequently have been withdrawn because they failed. The problem is the patient comes in, you can see 1 month, it looks good. 5 months, it's completely damaged and started to erode. So this is us. We do this in the office. We put the camera into our first MTP joint, and we're able to see that there's no cartilage at all left in the joint. And then we're going to find the implant, and the implant is in here somewhere. And there it is. It's countersunk completely on the head of the MTP joint, and the counter surface is completely eroded. But there's the implant. It's meant to be completely smooth. You can see it's pitted, eroded, and countersunk. So that needed to be removed. We also looked at a second MTP scope where a patient had a plantar plate tear. We were able to get in there. We were able to identify that again. We were able to bride that, add in a biologic at the time to create cicatrized tissue in there to augment plantar plate healing. All done in the office. Patient did well. We also do it in the knee. This is a Division I basketball player. He's going into the NBA. He had a notes that we did on him, and he ended up with, a year later, he was told that he had a large meniscal tear, he needed meniscal repair. That would have knocked him out for a long time. We said, why don't we look at it? We found a little flap of cartilage in there, and we were able to take that out. And a couple of weeks later, he's back running, doing all the things he wants to do. So what do our patients think?
I was able to see everything that Dr. Kennedy was doing on the screen, which was really helpful because I could see really what he was taking away, and knowing that now the scar tissue isn't there, so I am able to flex my foot further than I definitely was before, and I'll be 100% in a couple of days.
All right, well, that's a lot of self-congratulation. Not every patient is happy as that, but that was just, again, to underscore patients really like this procedure, and I think it's the wave of the future. I think we are going to be more like a dental facility where patients come in, have the procedure, and walk out, rather than bringing every patient to an operating room. I do believe this nanoarthroscopy, or in-office needle arthroscopy, is the way to go. So in summary, it can facilitate a diagnosis of intra-articular pathology, a simple bedside procedure under local anesthetic. The simplicity of the procedure allows the patient to observe, critical, and they buy in and become part of the team. And I think we have this whole array of instruments now that not only do we have the ability to see what we're doing, we have the ability to do within the joint and within the tendons. So that concludes my talks for today. Many thanks indeed.
Muchas gracias, doctor Kennedy. En aras del tiempo les agradecemos al doctor Thiago Fuchs, al doctor Javier Martín y al doctor John Kennedy por sus excelentes charlas. Hemos excedido un poco el tiempo, o bastante el tiempo en realidad, entonces lamentamos no tener momentos para las preguntas, pero los invitamos al coffee break y a visitar el stand comercial. Muchas gracias.